Karibuni sana kwa kipindi cha kwanza, siku yetu ya pili ya mkutano wetu wa kuwezesha sauti za waathirika na wagonjwa waliokuwa hayawapi kipaumbele kuweza kusikika. Na tutaanza mkutano wetu kwa kupata mambo ya jana kwa kifupi kutoka kwa Doctors Lorraine na Cecilia. Karibuni.
Mangwanani akanaka mose nogamuchirai kuchikamu chekutanga chemusangano wedu muzuva rechipiri ranhasi tichinzwa mastorizi enyu nezvatinokwanisa kuita kuti tidzore nekupedza ma-NTDs. Tichatanga nepfupiso ichapiwa yezvatakaita nezuro, iyo ichapiwa naDr. Lorraine and Cecilia.
Good morning once again to you. As Louisa mentioned, we'll be giving a recap of yesterday's meeting. So to start off, we had Dr. Paul Kazioba, who highlighted the purpose of the meeting to set the agenda in motion. And the purpose was to amplify the voices of the affected, to accelerate efforts to control and eliminate NTDs.
Habari ya asubuhi. Kwa kwanza tunapenda kuanza kwa kuonesha jana jinsi gani Dr. Kazioba alizotoa summary au kwa ufupi kuhusu mambo ya watu walioathirika na magonjwa yaliokuwa kipaumbele.
Mangwanani mose tavakupa pfupiso yezvakataurwa mumusangano wakaitwa nezuro. Dr. Paul Kazioba vakataura nezvechinangwa chemusangano icho chinova chekugadzirira urongwa hwekuti tingaenderere mberi sei tichinzwa mararamiro enyu uye zvingaitwe kuti tikurumidze kudzora nekupedza zvirwere zvakarekerera.
And also we had Dr. Shahali, who presented on the behalf of the Director of Preventative Services, who acknowledged the relevance of the meeting and the need to unite and fight NTDs, shedding light on the contextual issues, helping affected individuals to manage their diseases. And she also endorsed and echoed support for the meeting and expressed anticipation of a full report to help in the implementation on how affected voices will accelerate NTD elimination.
Na pia tulikuwa na Dr. Shahali ambaye alikuwa anaongelea kuhusu masuala ya NTD na kuonesha namna gani wagonjwa waathirika wa magonjwa ya NTD wanapokuwa athirika, lakini pia wanapohitaji ushirikiano au kusaidiwa wakati wamekuwa wameathirika.
Dr. Shahali avo vakamiririra mutungamiriri wezvepreventive services in Zanzibar vakasimbirira nezvekukosha kwemusangano uyu mukubatana kurwisa zvirwere zvakaregererwa. Vakajekesa nyaya dzemamiriro ezvinhu kubatsira vanhu vanorarama nezvirwere zvakaregererwa kuti vakwanise kuzvichengetedza mumagariro avo. Vakabvumazve kuti zvakakosha kutsigira zvese zvinenge zvataurwa mumusangano uyu.
We also had an update from the meeting that was done in Zimbabwe last year, December. And Prof. Mduluza talked about how lived experiences of people affected with entities has shaped the need to amplify the voices affected so as to tackle entities.
Pia tulikuwa na Profesa Taka ambaye alitoa kwa ufupi nini kilichofanyika Zimbabwe mwaka jana mwezi wa 12 kwa wagonjwa hawa walioathirika kwa magonjwa haya ya NTD.
Profesa Mduluza vakataurawo nezvemararamiro evanhu vanorarama nezvirwere zvakarekererwa muZimbabwe, vachitaura kuti zvoni zvakakosherei and zvakakoshera kunzwisisa mararamiro anenge achiita vanhu.
We also heard from the individuals affected by schistosomiasis, lymphatic filariasis, and snakebite envenoming. And we'll not get into much of the details as Frida will be giving the summary of those.
Lakini pia tulikuwa na mgonjwa mmoja aliyeweza kuongelea jinsi gani ameathirika na alivyojitambulisha, lakini hatutaenda kwa undani kwa sababu Frida atakuja atatoa kwa ufupi.
takanzwawo mararamiro evanhu vanorarama neschistosomiasis, vakarumwawo nenyoka nevanorarama neelephantitis. Asi Frida ndiye achauya achitaura zvakawanda pamusoro pazvo.
Thank you.
Asanteni. Matabase.
Nashukuru sana. Thank you very much, Dr. Favai and Dr. Oiso. So that was a great summary of the events that happened yesterday, from the keynote speaker to what are the key messages we took from the keynote speaker, to the summary from Professor Dluza, and all the way to the affected voices. So without further ado, I will call upon Frida, who will be summarizing the main message from the affected voices, where they voice their opinions and challenges faced that they need to address to make their lives more manageable. Thank you, Frida.
Good morning. My name is Frida. I'm going to summarize about yesterday I was discussing. Here we have different people. We have the affected voice. We have the one who has affected with snake bite, schistosomiasis, bilharzia, and lymphatic filariasis. On lymphatic filariasis, we have 3 patients. We have 4 patients, 2 from Tanzania, 2 from Zanzibar, and schistosomiasis, there's 2 patients, 2 affected from Mwanza, and the other one from Zimbabwe, also 2 which affected with snake bite. And the key message from those who are affected, they want the government to support them on provision of health education in order to reduce stigmatization. Also, they need health insurance on performing their treatment. Also, they need skilled health carers who can support on their treatment. Also, they need equipment on their diagnostic tools. Thank you.
Thank you, Frida, for the summary, for the voices of the affected. So I'll move on to the talk by Dr. Crescentia. Dr. Crescentia will be will be giving a presentations of the findings in Tanzania on the community affected by intestinal schistosomiasis with a history of blood vomiting. Thank you.
Good morning, everyone. I hope you're all having a great time and you are ready for the second day of our meeting. As I introduce myself, I'm Crescentia Chombola. I'm a medical doctor working at Catholic University Health and Allied Sciences in Schistosomiasis Project, Mwanza, Tanzania. And this morning I'll be giving a summary of the field activities that we did at Ukerewe District in March this year. Okay. For the introduction part, schistosomiasis is a neglected tropical disease, and among other neglected tropical diseases, there are more than 20 of them which were identified by WHO. And this affects more than 1.5 billion people worldwide. And the cause of these diseases may be parasitic, bacterial, viral, or fungal. And they mostly affected the developing countries because they're associated with poverty. So what's the effect of these conditions? They contribute to 0.2 million deaths and loss of 19 disability-adjusted life years. So this is very important because it affects all aspects of human life. So the key point here is that although we are improving the efforts in controlling and eliminating neglected tropical diseases, there is one aspect that is still neglected and it's not prioritized. This is the relationship between disability and neglected tropical disease. Kwa kwanza nilikuwa natoa ufupisho wa magonjwa ambayo yalikuwa yapewi kipaumbele, na kwa kuelezea hayo nitaenda pia kutoa ufupisho wa kazi ambayo tumeenda kuifanya kwa wagonjwa ambao wanatapika damu wa Ukerewe kwa sababu ya kichocho. Kwa hiyo ni kazi ambayo tuliifanya March mwaka huu, na nitaenda kuleta matokeo yake na kuelezea hapa. So, on introducing schistosomiasis, among the prevalent conditions in sub-Saharan Africa, schistosomiasis is one of them, and we have two types of schistosomiasis. The main two species causing schistosomiasis are Schistosoma mansoni, that causes intestinal schistosomiasis, and Schistosoma hematobium, that causes urogenital schistosomiasis. It is estimated that 93% of the 290 million people that are affected with schistosomiasis live in sub-Saharan Africa and accounts for more than 2.8 million disability life years, adjusted years. So after Nigeria, Tanzania ranks second on being more prevalent with schistosomiasis. And numerous studies have identified that on the main two types of schistosomiasis, intestinal schistosomiasis is more prevalent in areas around the lake. Ukerewe being among them because it is surrounded by a lake and has a lot of islands. As I stated earlier, the main causative of intestinal schistosomiasis is Schistosoma mansonii, and this is associated with a lot of morbidities, hepatosplenic morbidities. So for these endemic areas in Ukerewe district, which is just an example, in northwestern Tanzania, but there are a lot of districts which are prevalent with intestinal schistosomiasis. There's Buchosa, Sengerema, and we receive patients from all over those districts. So Ukerewe is just an example, and one of the areas that has got the opportunity to be reached with morbidity management program. Chronic schistosoma mansonii infection accounts for 8.5 million cases of hepatosplenic schistosomiasis, and in Tanzania in 2012, it was estimated that the prevalence of schistosome infection was 51.5. And among that, 51.1% of upper gastrointestinal bleeding were due to esophageal varices, and this study was conducted at Bugando, which is a zonal referral hospital. Then 70% of upper gastrointestinal bleeding were due to esophageal varices, and 10% died within the first 4 weeks after being discharged. So vomiting blood, one episode of vomiting blood is a risk for another episode of vomiting blood if not proper management is taken. There's also a study was done on morbidity, which shows that 50% of adults had periportal fibrosis. So why vomiting blood? What happens is when the cercaria, which is the infective stage of the schistosome, interpenetrates the skin and enters through the blood circulation, it goes and resides to the liver and affects the portal veins. Portal veins are the big veins in the liver. What happens is our body reacts to those eggs and causes fibrosis. Fibrosis is hardening of the vessels. So as a result, this results into portal hypertension. It's like when you have a pipe of water and clog it with dirt inside, then the pressure increases. So this brings effect to all of the vessels that are associated. We call them plexus, the association of vessels from the liver, the spleen, and the lower part of the esophagus. And as a result, it causes esophageal varices because it tries to compensate by forming new vessels on the lower part of the esophagus, which causes varices. So when you have varices, the very soft part of the lining of the esophagus is exposed to trauma, and as a result, an individual vomits blood. So sometimes the bleeding may not be severe enough to cause vomiting blood, but it may cause black stool because the blood will go through the GI system, and the stool will be black because the blood will be digested throughout. So what the main manifestation in chronic morbidities of schistosomiasis is splenomegaly and vomiting blood. These are the two main, and they are caused by portal hypertension. But in addition to that, there's also ascites, which is accumulation of fluid in the abdominal space, which is also caused by portal hypertension. So portal hypertension is the culprit, the increase in pressure in the big vessels of the liver. The main management, there's a series of management, but the main management in our country is diagnostic and therapeutic endoscopy. This endoscopy is, as you can see on the picture, a scope enters through the mouth and visualizes the esophagus throughout to the stomach, and therapeutic endoscopy involves bind ligation. So when they find the varices, the bulging vessels, as you can see on the picture below, they tie them. Then they leave them to heal. That's the management, the very important management. But in addition to that, there's also medical management, which involves drugs that help to lower the portal pressure. So these are the esophageal varices as visualized in the screen. So this study was conducted in Ukerewe district, Manda region, which is northwestern Tanzania, and it's just one of the districts endemic to intestinal schistosomiasis. There are a lot other more. The district is made up of 38 islands, and of which 15 islands are permanent inhabitants and 23 are fishing camps. So the main activities in Ukerewe district are the risk factors of intestinal schistosomiasis, because most of the inhabitants earn their livelihood through agriculture and fishing, which keeps them in continuous exposure. It was a hospital-based concessional study because we interviewed participants that we recruited in our program, a program that deals with mobility management, where we recruit patients from the villages through the community health workers, the village leaders, and the health workers in the primary level of the So we recruit patients through them. The study population comprised of patients attending endoscopy unit at Nansio with chronic morbidities due to intestinal schistosomiasis. We were sampled conveniently. So the participants that were recruited were above 18 years, and the exclusion criteria was those who did not consent and those who were in the wards who were not clinically stable. The data was collected using COBOL Collect and analyzed descriptively by using statistical package for social scientists version 20. This is the picture of the district hospital, Nansio District Hospital, Ukerewe District, where we partnered with them and they gave us one of their buildings and it is used as endoscopy unit. Coming to the results, in the demographic characteristics, we interviewed a total of 34 participants, of which 76.5% were male, and the age of the participants ranged from 30 to 80. Of the 34 participants, 8 participants currently work. The rest of the participants don't work due to the condition. And those who work, 3 of them are farmers, 3 traders, and other had other activities. So of all participants, 26 participants knew that they had a neglected tropical condition, and 25 participants also received the unofficial diagnosis. And majority of the participants completed their primary school. The mean duration from when the condition started was 4.9 years, and majority of the participants have been having the condition for 1 to 5 years. But we have like 3 participants who have been having the condition for 16 to 20 years, which is a very long period of time. And on the clinical presentation of the participants that we interviewed, majority of them presented with vomiting blood, which is 61.8. 55.9% of the participants presented with disfigurement or deformity, which is abdominal distension, and 20.6% of the participants had both vomiting blood and abdominal distension. These are the key presentation of the participants we interviewed. So what was the outcome? What were the results of the study? So in activity limitation, 5.9% and 17.6% of the participants reported difficulty in self-care and mobility respectively. But none of them required assistance of aids in performing those tasks. 14.7% had difficulty moving away from home, and 1 could not even move around home. So she completely relied on relatives and help from others to do house chores in the house. So these are the graph presentation of the results as it is displayed. So 33%, 97.1%, which are 33 participants, reported restriction in everyday activity, which is caused by the condition. And the cause of restriction in the daily activity was for 2 participants chronic pain, 3 participants shortness of breath, and the rest of the participants due to the condition itself. Majority of the participants reported being limited in their daily activities, and which included their economic activities, which are 31 participants. So currently only 8 participants currently work. So what activities they can do right now? Majority of them, 79.4%, they can only do non-manual work compared to the condition prior the illness. And one of them cannot do anything, cannot do either manual or non-manual work. So these are the illustration of difficulties that they get in employment. Majority of them reported that it has affected the type of job they could do and the numbers of hours they could do. So before the illness, they could work for many hours, they could do any type of job, but after the illness, it restricted them. It led them to do only non-manual work. We are coming to the last part of the result, which was on knowledge on rights protection in people with disability. So majority of the participants, 88.2, were not aware of any national umbrella that deals with people with disability. And on participation, on community participation in political and public life, 67.6% of the participants reported that people with disability do not participate in the public life and the political activities, which is very huge and very significant. Majority of the participants were not aware of the rights protection for people with disability, and on the delivery of healthcare services, 30 participants think that the emphasis should be in the following order: prevention being the most highly to be focused on, followed by rehabilitation, individual support, accessibility, and the last one being anti-discrimination law. Of the 34 participants, only 8 participants had an idea of the official recognized disability policies. So this also highlights and stresses more on the knowledge of policies in disability and rights protection. And the graph below shows the responses of the participants on the benefit to be provided to people with disability. So these were the recommendation of participants we interviewed, and the following were their responses. That the most important thing in the service to be delivered to people with disability is medical care and other healthcare services, where 91% of the participants responded to this. So what message have we got from the study? From the demographic characteristic, we have noticed that the majority of the participants were male, and this is consistent with other multiple studies in neglected tropical disease, where most of the affected with chronic manifestation of NTDs are male. Also, we have seen that the majority of the participants were aware that their condition is an NTD, but this can be explained by the fact that the participants that we interviewed were from the program, so they are already on management, they already know their condition and the impact of the condition. We saw that on the results part, only 6 participants reported that after contracting schistosomiasis, received immediate treatment. What does this tell us? This highlights the challenges in diagnosis of schistosomiasis and early treatment. In addition to that, the fact that the 6 participants still progressed to chronic morbidities shows the nature of reinfection of schistosomiasis in endemic areas, which is expected because they're in continuous exposure. In activity limitation, there are 2 parts. In activity limitation to daily activities, for example, taking shower, wearing clothes, the limitation was lower compared to other studies in neglected tropical disease, and this can be explained that the selection of study participants were only clinically stable patients. So we did not interview clinically unstable patients. That's why the results came. In activity limitation in their work, it is consistent to the results in other studies, like the study in Indonesia, which showed that there's 60% limitation in activity in the world. In addition to that, we have seen only 8 participants currently work, and this stresses more on the impact of these conditions in income generating activities, so facilitating the vicious cycle of poverty. 67.6% of the participants reported restriction of participation of people with disability in political and public life. This also is consistent with the study in Indonesia, where it was 60%, and aligns with the study in Ethiopia, where it was 55.1%. And this highlights the restriction in participation of people with disability in the community and in the political activities. And generally, the majority of study participants had no knowledge about the rights and policies protecting people with disability. So what can we do? This was to complement this study, a qualitative study should be done where stakeholders from the community drug distributors to the healthcare workers, they should be conducted focus group discussion and in-depth interviews so as to exhaust more on the experiences and opinions in the community so as to complement the available results. Another key issue here is the relationship between disability and neglected tropical disease, which is often not prioritized, so it should be an area of focus in the coming studies. And emphasizes on comprehensive approach in controlling and eliminating schistosomiasis is important, because in the national programs in Tanzania, the focus intervention is the mass drug administration, but we forget that there's other parts of the group that is affected with chronic morbidities who are suffering and are not able to get management. So the key message here is that mobility management should be part of the national programs so that to enable all people who are affected to get the treatment. Another thing is the national burden of the morbidities. Studies should be done to determine the national burden of the morbidities that will enable us in planning for future programs in mobility management. And at last, to attain universal health coverage, no group of individuals affected with chronic manifestations should be left behind. So to achieve this, it's important that we strengthen the primary healthcare system, which are able to reach a larger population, so that to enable those who are affected and cannot access the medical care to get the treatment they're supposed to get. In conclusion, intestinal schistosomiasis is a public health concern, and for this study is conducted at Ukerewe district. It's just an example, but there are a lot of other islands in Ukerewe district that are suffering from this and need help. So the important thing is the inclusion of management in the national programs, which will help to improve the quality of life and save lives. So from our program, we've experienced that there's no need for people to die due to vomiting blood, because when they come to the hospital, they get the right management, endoscopy is performed, bile ligation is performed, they get the medication and they use them correctly. This restores the quality of life, then they go back to their normal activities and they can earn money and get back to their families and support them normally. Another important key issue is the connection between neglected tropical disease and disability should be a focus, and to attain the goal of eliminating NTDs, we cannot leave this aspect, which is very important. So these are the pictures of the beautiful Ukerewe. Asanteni sana. So in addition to that, to wind up the presentation, I would like to give the summary of the experiences and opinions of the healthcare workers that we work with them in our program. At Ukerewe district, before the initiation of this program, the situation was worse. The medical wards were full of people vomiting blood. The blood that was available in the lab was not enough, for the people, and it led to a lot of death. So prior to the onset of this program, the condition was very worse. And we received help from different people, the community drug distributors, the village leaders who are aware of the condition. And right now, even the participants themselves know, when I see my fellow vomiting blood with abdominal distension, probably this is schistosomiasis, and I inform her to go to the hospital. But we have just reached at one district. There are a lot of other districts that need help, and for the program itself, it cannot sustain everyone. So it's important that awareness is being raised and the stakeholders to know that this area is important and there are a lot of people who need help. Another thing is the experience was most of the patients go to the hospital in the later stage. So when the first presentation normally is abdominal swelling, which is somehow small, then it progresses with time, but most of the time it's not painful and it does not bother them. So because they do not have money to go to the hospital, they stay with the condition for a long time until when they vomit blood, that's when they go to the hospital. And when they go to the hospital, the district hospital, there's an endoscopic unit that the program organizes, but it's not available all the time. So they refer the patients to the referral hospital, the zonal referral hospital. So most of the patients, almost all of the patients do not go because they cannot afford even the transport from Ukerewe to Mwanza. They cannot afford even the transport. Okay, leaving out the transport, even if they get there, the management itself is expensive. To conduct an endoscopy, it's almost $100. That is just diagnostic endoscopy. Therapeutic, where we do bone ligation, it comes up to $180. And that's why I'm talking to the patient who came there stable, not admitted in the hospital. But if you're admitted, you have to pay for the bed, for the nursing care, and everything. So it's very expensive. So most of the patients do not go to the hospital. So the cycle is, they vomit blood, they go to the district hospital, blood is being transfused, they go back to the community again with the medication for 1 month. They cannot afford to continue to buy the medication. They vomit again blood, they go to the hospital, and until it reaches a day where they vomit blood massively and they cannot reach the hospital, they lose life. So that was the situation in Ukerewe. So this is very important, and I hope it reaches somewhere where we get help as a national, not just as program, but as a national, so that we can help a lot of people. Another challenge that they explained is the co-infection with other infections, liver diseases, for example, hepatitis. So schistosomiasis itself, it affects the liver, but does not compromise the function of the liver. So if the patient gets proper treatment, recovers well, and restores back to the healthy life. But the problem is the comorbidities with other liver diseases, which makes it a challenge. And to the part of the participant, the biggest challenge was the expenses of transport. Even if we're doing the program, for them to get money to come to the hospital is still a challenge. So that is the part of the participants' feedback. Thank you, and I welcome if you're having any questions or comments.
Thank you very much. I think we'll have the translations first, but in summary, because you spoke a lot, but it was an interesting talk. Thank you very much.
Nitakwenda kutafsiri kwa kifupi kwa sababu ameongea vitu vingi. Kwa kifupi, Dr. Fetesia ametupitisha kwenye overview ya masuala ya Kristo katika study ambayo imefanyika katika kisiwa cha Ukerewe. Kwa kifupi amesema kwa kuanzia kwanza, kichocho ni ugonjwa ambao umewaathiri sana kisiwa cha Ukerewe kutokana na kazi ambazo huwa wanafanya katika lile eneo. Wao economic activities, kazi zao za kujiingizia kipato ni fishing, ni kilimo pamoja na uvuvi. Hizo ndo kazi zao kubwa katika hayo maeneo. Kwa hiyo wameweza kuathirika kwa kiwango kikubwa cha ugonjwa wa kichocho kwa kupitia hizo kazi zao, na waliweza kufanya study kwa watu 33 ambao waliweza kuwapima na kuangalia namna gani wameweza kuathirika. Na asilimia kubwa ya hao watu ambao walipimwa walionekana walikuwa walishaanza kutapika damu, ambayo walishaanza kuathirika na ugonjwa huu wa kichocho. Lakini katika hii study, waliwauliza participants maswali kuhusu mambo ya watu wenye ulemavu. Wengi walionekana wako aware, lakini kuna wachache walionekana wanajua kuhusu mambo ya policy, sera kuhusu mambo ya watu wenye ulemavu. Kwa hiyo mwishoni akasema kwamba ni muhimu kuweza kuassociate disabilities pamoja na masuala ya NTD, ili hawa waathirika ambao wameathirika na magonjwa ya NTD waweze kupata msaada, waweze kusaidiwa. Lakini pia mwisho akasema pia katika study iliyofanyika kwamba ukiangalia katika vituo vyetu vya afya, ile management ya kichocho bado ni tatizo kubwa, na bado wanahitaji msaada, na sio management tu, lakini pia na vile vifaa kwa ajili ya kuweza kupimia na kuweza kujua kwamba mtu ameathirika na ugonjwa wa kichocho. Bado ni tatizo na ni gharama. Kwa hiyo unakuta wagonjwa wengi wanashindwa kwenda kwenye vituo vya afya ili kuweza kusaidika, na mwisho wa siku anaweza kupoteza maisha. Asanteni sana.
Pachiona nyaya yatsanangurwa na Dr. Pili ndoti yakakurira mberi setsvimbo, ndobva yazoshonyoroka segumbo rembwa rekumashure. Saka changoti gagaka zaitika parambe kuti vatsanangudza kuti chirwere cheshisto chemudumbu, vanga vasingatauri chimwe chacho cheweti, taura chemudumbu, chakawanda, chinouraya vanhu vanosvika 0.2 million, inongori 20,000 pagore pasi rose. Asi chakawandira munyika dziri kubudirira dzakaita seAfrica or Southern Africa, kuno kusub-Saharan Africa ndiko chakawandira. Vatsanangura mapicha atationa aya kuti chinenge chakaita sei mudumbu macho, vachiti chinokonzeresa kuti ropa rinogona kuwanda mumatumbu, rimwe racho rinogona kubuda riri ropa kana kuti rinozodhaijestwa zvekuti harizooneke parinobuda kuti ropa, asi rinenge riripo nemuchina rinooneka. Vataurawo zvakare kuti chinokonzeresa kuti muite puresha, inoita kuti ropa rizobuda dzinguri mazai anenge abaya mukati matumbu, unga mazai aya timaziva anenge kugonyoka soka muswe kanobaya, kozotiwo puresha yekuti matumbu anotsemuka, ropa robva razobuda. Zvakawanda zvataurwa zvakaratidza kuti hanzi paresearch yavo vanhurume ndivo vanowanzo kubatwa nechirwere ichi, tingati vakawanda kudarika vanhukadzi. Zvikonzero zvacho kudatozviziva, varume vanyanya kufarirawo zvekutuhina. Right. Tobva ipapo pazotaurwa nyaya yekuti vanhu vacho vazhinji vavakaongorora patsvakurudzo yavo vakaona kuti vanotoziva kuti vane chirwere ichi nekuti vakatoenda kuchipatara vakatonyorerwa kuti vanacho. Asi chanyanya kunetsa ndechekuti vanhu vanozoziva kuti vanacho chatova pane imwe stage iri kunzi iyo early diagnosis yakanyorwa ndonga pamusoro apo pasentence yekutanga iyi early diagnosis apa kuti uzikanwe kuti unacho zviri kutora nguva ndo panoda kuti pashandiwe ipapo. Pakupedzisira vazotaura kuti zvinhu zviri kudiwa ndakuita sekudzokorodza kumusoro wenyaya ipapo pakuti munhu anacho akurumidze kuti kuzikanwa kuti ane chirwere ndopari kunetsa. Zvichida panenge pachitwa mamistake yekuti akuda ndechimwe chirwere chakati kuda ndechakati kuda ndechakati kusvika azobatwa. Izvo zviri kukonzeresa kuti munhu azobatwa kuti ane chirwere nguva yatopera zvokuti dzingonguri anononokerwa. Ndatenda.
Thank you very much. We still have some time for this session, so if I'll open to anyone who has a comment or a question to Crescentia.
Thank you, Crescentia. May I ask a few questions to you as a clinician? Because in Zimbabwe we have a lot of hematobium, but not so much of Mantonite. This issue of blood transfusion is a very important issue. So I was wondering, first of all, do patients need repeat transfusions? And if they do, how many pints of blood you normally give? And then the last question, I'm really thinking from a public health perspective. What would you say is the annual, if you have the figure, the annual need of blood for transfusion? And then the fourth question, because in Zimbabwe we have to pay for our blood for transfusion. Do you pay for the blood when you get a blood transfusion in Tanzania? I'll repeat for my colleagues from Zimbabwe. Saka nditi hanzi manzwa kuti chirwere chemudumbu chebharazia remudumbu kwete remudumbu vanhu vanorutsa ropa. Kana varutsa ropa pai vanotoda kuwedzerwa ropa. Saka ndabvunza chiremba kuti kana munhu arutsa ropa muchiti ngaachuye awedzerwe ropa, anoramba achiuya kuzowedzerwa here kana kuti anowedzerwa kamwe chete? Uyezve kana vachiwedzerwa ropa iroro vanoda mabhegi mangani eropa? Ndichizotevedzera kuti pagore kana mune vanhu vamunoshanda navo mucommunity vanoda ropa rakawanda sei? Ndekuti kana tiri kuZimbabwe tinobhadhara ropa, saka tinenge tichida kuziva kuti ropa iri rinoita mari.
To respond to those questions, the first one, the kind of blood that they are transfused with is the whole blood. And the need depends with the hemoglobin level of the patient. We measure the amount of blood by hemoglobin level. So less than 7 is severe anemia, and that person requires transfusion. But sometimes because of the scarcity of blood, you might find you consider the clinical presentation of the patient. So even if it's severe anemia, maybe let's say 6, but clinically the patient is stable, you do not transfuse because of the scarcity of blood. And how do you manage this in Tanzania? Normally for the cases of blood transfusion, when the relatives come, if your relative is admitted and is being transfused with blood, the relatives are supposed to donate blood. That's how we maintain the blood in our lab. I do not have the number. I do not have. Yes. The last question.
Yeah, thank you very much, Crescentia. I wish to add on top of that, like other components of blood
they might be needed sometimes, like fresh frozen plasma, depending on the severity. But most of the time, these patients, they go to shock. So they do resuscitate with the fluid. And we don't, patients or clients, they are not paying for the blood transfusions. Most of the time, they are a certainly, what do I say, the team, like the hospital itself with the other stakeholders, they have organized, like, there are these people who are officially go to school, children said collect blood. These are done routinely, monthly, weekly, so that we have a stock of blood. Sometimes we run short of it, but we normally find from different hospitals. We normally shout for help in different facilities.
I noticed it is a big problem, especially vomiting of blood. What is the status of the policy, for the affected people? Because if it's a problem which is occurring frequently, the policymakers need to be sensitized that there is this group of people, they need special care. So I just wanted to find out from Tanzania, and people are heavily affected by this condition. You call for blood, you do what, and how much is the policy addressing that problem from the government, that this group of people, they need assistance? Thank you.
So I'll respond to that, and I'll ask Professor Humphrey to elaborate more. But for the national programs that are available currently, they do not include mobility management. That's just mass drug administration. So it's the problem, and this is just the beginning of shouting for help.
Yes, in terms of policy tracker, so far we are using what is in the WHO. In this country, mobility management in terms of schisto is not there. And we are the only group who are still doing ultrasound to live from the community, also to the hospital setting in the endemic areas, in all the age groups. But for the program itself, they don't have any data related to mobility. And there is no any plan for mobility management. And I can say that even for the massive drug administration, we don't receive drugs for the adult people. We only receive drugs for the school children. Even for our project, we are just keep putting a lot of energy to get the drug from the Ministry of Health. So we are just using the other doors to make sure that what is remaining the primary school children is what we put in the adult population. But our budget, there is no drug for the adult population. Yeah.
Okay, thank you very much. I'll take Godfrey's question. We have 4 minutes. So Godfrey, and then one more.
Thank you very much for the good presentation. I wanted to ask on those who remain behind in the community, because you said you selected 34 participants based on clinical signs and symptoms conveniently. So I wanted to know on health seeking behavior, like for early treatment, is it not possible maybe to screen the community before the disease progresses? Both from your findings, you were saying that most of the patients that you see, they progress into complication. So maybe if to find out the prevalence, since there is a gap in diagnosis, where you talk, there's some patients, they don't have money, they stay far away. Can the program also be extended to the community for screening, something like community awareness, a program to screen those who are not yet coming to the hospital?
The 34 participants we interviewed were from the cohort, which is part of the program. So it's just a part of the cohort, but we provide service to many patients. For the screening part, we have project activities that are implemented in the communities for screening and identifying the prevalence of chronic morbidities in schistosomiasis. But the real challenge is here is we just cover some few villages, about 20 villages, and just by Okerere district itself have at least 40 villages. So there's still a need to add more effort.
Thank you, Crescencia. Mine is not a question, rather a comment. It's a follow-up comment to Taka's question and response and Humphrey's response. This is a very, very compelling evidence that we need, I don't know whether if I say policy change or a completely new structured sort of regulation or policy which will cater for victims of NTD, colleagues who have disability, permanent disability. So my question, no, I'm not asking you, I was just thinking aloud. How can this be done? Whose business this should be? Because if we think of the program has been there for many years. They go, they visit all these districts, they do community engagement for MDAs and so forth. I'm convinced that they must have been seeing some of these patients. Unfortunately, they didn't even bother. So we now have evidence, better evidence ever, to now put down a document which will convince decision makers to come up with a special program for the affected. Yeah, NTDCP, I'm not convinced the program can do this because they do business as usual. We know the programmatic activities are routine, very, very little innovations. Should we do something with the routine healthcare system, the structures, like the primary healthcare where majority of the affected lives or seek care? Well, this is another challenge because we know the capacity of a primary healthcare. Or should we come up with a special national program which will be focusing on the affected, irrespective of the nature of the disease, whether it's schistosomiasis, whether it's LF, whether it's blinding trachoma, whichever, a special program dedicated to cater for the needs of the affected, given the amount of evidences we already gathering from your research, from what we heard yesterday from the affected in Zimbabwe and Tanzania and Zanzibar as well. So we have enough evidence. This pushes me to think like now we have something to write and tell decision makers, this is the situation, this is what we want. Asante, thank you so much.
Thank you very much, Dr. Kazioba. I'm sure we'll go on and on about this discussion, and it was quite a thought-provoking presentation with very good evidence on why we're here and how we should come up with policies. So we're 1 minute out, so I think we'll move on to the next. Okay, I will permit for this, sorry.
the question on the communities when we are screening what is happening. This is a cohort of almost 4,000 people with ultrasound, and this is a prevalence of portal vein dilatation, which is a good example of what Crescencia was saying, having many people vomiting blood in this community. So if you have this picture, you see from the age of 14, you can end up with children starting vomiting blood. So portal fibrosis started ill in this community, and the patients who are coming out from the age of 36, the majority who are coming up with bloody vomiting issues. What just presented is just 30 patients. We have a cohort of 300 and something patients who are attending the endoscopy unit at this district hospital. And there is a service which you cannot get at the level where we have put it. Normally at the regional hospital, where patients have to go, or at the tertiary hospital. And at the regional hospital, it's just become in the past 2 years from the COVID fund. So the country decided to put the unit at the nearby regional hospital. But at the district level, where we put this patient can access, it's not easy. And we are almost attending 120 patients every month with vomiting issue. And we need like 10,000 euro for a cohort of 120 patients. So it's not easy.
Thank you very much. So I think we're running out of time, so I will have the next speaker. That will be Professor Hassan, who will be giving an update from Sudan. Yeah, thank you.
Good morning, all. We'll be learning, me and Professor Maawia, to bring the affected voices for NTDs from Sudan, but unfortunately we failed to brought them or to bring them here due to the severe conflict in my country. But I prepared some photo and videos for only one entities, Shishima Mansunai, affected person from Kassala State, mainly New Halfa district. And I will go quickly and fast on the beginning of the presentation about the NTDs and schistosomiasis control. And then I will focus on the videos and photo of most affected voices, Yosisus Home and Sunai in New Halfa district. Globally, there are 20 listed neglected tropical disease and classified according to the infectious agent, vary from elements and protozoa and viral and bacterial infections. Out of these 20 listed entities, there are 14 neglected tropical diseases in Sudan. Today, I will concentrate on schistosomiasis. And the most affected voices population in Sudan, the poor population living in rural and remote area, and those who are living in contact with infectious agents, and those who have limited access to the safe water and health facilities. The current epidemiological trends. People access to water for doing, for washing clothes, and fishing, and entertainment, and washing cars, and fetching water. Schistoma mansoni and hematobium highly endemic in the western belt, schistoma mansoni and schistoma hematobium, the schistoma hematobium hyperendemic in the western part of the Sudan, and schistoma mansoni highly endemic in the eastern part, especially in Kassala state. The key strategies, we always distributing preventive chemotherapy using mass drug administration. This is prazoquantel and ivermectin and albendazole. But distributing prazoquantel or preventive chemotherapy alone is not enough, and we need to implement other strategies. Provision of safe water, eliminating open defecation, and enabling the environmental and others cross-cutting strategies, vector control, and wash, water sanitation and hygiene, I mean. This is preventive chemotherapy, mass drug administration for lymphatic filariasis and schistosomiasis, and and the elements. In Sudan, there is still some poor people digging in the ground to collect the water and use this for drinking and domestic uses. So provision of water or soft water by using tank and pump hand is very important, and this can promote the people to avoid to contact to infested and contaminated water. The second approach is behavior change. Behavior change is very important, and as we saw here, people practices open defecation everywhere, and by building latrines, we can help the people and support them to eliminate open defecation. And the open defecation is a cornerstone in the transmission of schistosomiasis. Also, vector control, the intermediate source of schistosomiasis. We have two types of schistosomiasis, schistosoma mansoni and schistosoma hematobium. This is a Balanus truncatus and other species, and Biflaria fifrae. And also there is some species, Biflaria sudanica is available in Sudan. Also we find a persistent hotspot. Persistent hotspot, this means that there is some village, we determine more than 250 villages in Kassala state had persistent hotspot, because we distributed prazoquantel for two times or 2 rounds annually, and the prevalence is still very high among those villages. On the last baseline survey, the result, we select these villages. The prevalence of infection with schistosoma mansoni is above 70%. The affected voices for schistosoma mansoni in Kassala State, district of New Halfa. Those people presented the whole age group, pre-school age children, school age children, and adults. And all of those patients from the only 3 villages. So this is, his name is Hafiz. He is for 5 years from village 26, and he has obvious spleen enlargement and ascites, and he tested for sonography and catechase technique for stool and for anemia, and he found that he is brittle, and we interview him. So the interview in Arabic, and I can when we ask him why and how he infected with schistosoma mansoni, and he said it is difficult to him to access the health facilities, the health unit and health center, and the rural hospital is a little bit so far from his village, and this is also very costed for the for the transportation, and he have no money to buy the treatment of praziquantel because the praziquantel is not available in the health center, and he need to travel to the town or to the city to buy the praziquantel, and this is very difficult to him. And his occupation, he is a farmer, and he since 5 years he didn't go to the work due to the disability of Susom and Sunai. The other, his name is Muhammad Abdullah. He is 59 years old, and from the village 26. And here there is no video, sorry. And he obviously also visual signs of Susom and Sunai, size, and maybe also hepatomegaly, hepatosplenomegaly, and spleen enlargements and ascites. And also he stopped to go to the work for 8 years due to the disability. So the adult is, we can just shift to the school's air filtering. And this is Ahmed Usman, 10 years old. And also he diagnosed with spleen enlargement. I think this is a video. So Ahmed Usmani also diagnosed with spleen enlargement, and even he is very young. And in interview, he said he never took a praziquantel for Susom and Sunai. And this is Abdulaziz Suleiman, 11 years. Also, he is suffering from spleen enlargements and hepatomegaly. And there is a video. We interviewed his father, but I think this is a little bit wrong, and I can share with you later, maybe because of the limit time of the presentation. And this is Ramadan Abdullah. Also, he was diagnosed with spleen enlargement. And we interviewed his mother. She answered. In summary, all the people suffering from accessing to health facilities is very difficult to them because they live so far from the health facilities, and the availability of praziquantel in the health center near their village. The very sad things, the 3 ladies from one family, all they suffering from spleen enlargement. I will introduce them individually. This is this one. Her name is Summer, 8 years. And this is Amani, 7 years. And this is Asma, 5 years. This is a preschool age children. Very sad. From one family. And this is preschool children, only 3 years. His name is Sakatori, 3 years old. Sakatori Habib. Ahmed Sakatori, he's only 3 years old. Also, his mom said he feel abdominal pain, and when they went to hospital, they did stool examination, and they found that there's a diarrhea, and also they did sonography, and they found that also has spleen enlargement. His family, we don't know how. Challenge and gaps we need to put. This this treatment is not available in the hospital, and it is very important for aside and spleen enlargement and hepatomegaly. And the other one, internal 4 milligram, is also, and the others, carbidinol and pantoprazole, is all those for the hypertension of the portal liver veins. Provision of praziquantel and albendazole, and distribution of the operation course is very important. Preschool age children with the pre-SACS mapping, because until now we don't know the prevalence of preschool age children in the district, and the provision of clean water supply for the all rural and poor who live in remote areas. Thank you very much. I have very few comments. In Sudan, we have a problem with diagnostic tools. We use only katika technique for the stool, and this is we always suffering from the underestimation of the egg, and the accuracy, even the accuracy of the katika technique is very high, and we need to use CCA, acidic circulating antigen. I think this is very high accuracy and very sensitive test. Thank you very much. If there is any comment or any questions, be very good.
Thank you very much. I apologize for going over time, but I think it was it was important because we needed to hear the voices. So I apologize for going over time, but is there anyone with one burning question? Because we can have this discussion during discussion time later in the day, but anyone with a burning question or comment at the moment? Just one, I can allow one. I guess, yeah.
Okay, thanks. Sending shocking waves, especially under five. Those fallen automakers. Any advice you are giving to the mothers so that they can have their kids protect their kids. So there's something, yes, sanitation could be poor, but the mothers can protect their children. But that is really shocking. Seeing children with these abdomen swollen, they must behave. They can prevent something, whilst others yes. Thank you.
We just saw that Kassala state is most state that the people practices authentication, and we communicate with others NGO and our partner in Kumika, and they promise to help, and even we sign an agreement for a project for combating social misses in Kassala and other 5 states. But unfortunately, the conflict led Korean partner escape for the country, and then everything was stopped. And because that project is a comprehensive project, and, we will implement, or we plan to implement, like to eliminate authentication and other behavior change, and training other community volunteer. The community volunteer, we plan to train them and how to diagnose using CCA and how to distribute prazoquantel easily in their village. Those maybe, if happen, maybe reduce the prevalence of the suicide scenario among the villagers and among the adults and school-age children, and also preschool age. And I think for preschool age, around 3 years, 5 years, 4 years, this is need more study, deep study, to see how those children getting infectious or infected with this hormone.
Thank you very much for the talk. For now, we'll take a break. Since we went over time, I think we can be back by 10:40, and then we'll go to the next session. Thank you very much.
Good afternoon. Can I have your attention for all that you are outside? May you please come inside so that we may proceed with the session.
May we all please come inside and proceed with the session. Good afternoon again. So we are going to proceed with the meeting. We are having the second session of day 2. And I would like to welcome Godfrey Dandajena, the HO of Shamva District, for the experiences of the nurses and community health workers from Zimbabwe. You're welcome.
Thank you very much for giving me the opportunity, the experience. So in this presentation, I will share with you the background of our district. Then we'll look at some of the data that we have with regards to other entities. Then we'll also look at policy issues in terms of case management, disease control, and also some of the field investigations that we have done. NTDs are viral parasitic bacterial disease. Usually, this disease is prevalent in poor communities. Despite their prevalence and devastating impact, they are actually on the increase. They receive limited funding, but of late we have started having media coverage where documentaries they are being done to try and have the disease known to the community. The low water and sanitation coverage is a driver for NTDs, particularly in the rural. It's a comprehensive approach that is which is intersectorial for foster prevention, treatment, collaboration, and also active community involvement. In other instances, maybe active case search. This was also said by the Health and Child Care Permanent Secretary for Zimbabwe. Although this disease have got higher morbidity, but they are usually overlooked and underfunded, and pose a significant threat to health. There are 20 conditions which constitute the NTDs, but in Zimbabwe there is leadership and governance structures. They are in place in terms of maybe the institutions who are in charge of these NTDs at national level. We've got at national level, we've got the NTD policy making body. But however, what is lacking, it is maybe the technical support. That is maybe how best the programs have to be done. Although such institutions exist, but the technical aspect in terms of what best needs to be done to maybe roll out the programs to the maybe province, to the district, and also to the rural periphery. So usually the policies they exist, international level. In Zimbabwe, 4 entities are common, although we've got other, such as intestinal worms, rabies, leprosy, sleeping sickness, anthrax, plague, snake bites, other foodborne trematodes. But however, bilharzia, intestinal worms, elephantiasis, blinding trachoma, these are the main cause of morbidity in Zimbabwe. Here, I'm showing you the map of Zimbabwe, which is showing us the 10 provinces which constitute Zimbabwe. And you can see Mashonaland Central province. It is a province where Shamba is located. But compared to other provinces, Mashonaland Central, it has got a high prevalence of these entities, and particularly Shamba, it has got a profound number of cases in terms of prevalence. So you can see Shamba, you can see Mashonaland Central province, which has got 8 districts. From the districts, you can actually see Shamba in light blue. Shamba and also Musalabani, they've got high prevalence of these entities. In Shamba district, it is segmented into Shamba North and South. In Shamba North, where it's shaded green, we've got the wards which has got a high prevalence of these entities. And you discover that we've got wards such as Chewakadzi, Mfurudzi, which has got distinctively high cases of entities like schistosomiasis, which is the upper part of Shamba district from 29 wards. The district population of Shamba is 108,040, and we've got 19 health facilities, 2 hospitals, and 17 clinics. Shamba is a mining community, and particularly we've got artisanal miners who move in search of gold. Also, in areas such as Mfurudzi, Nyamaropa, we've got agricultural activities, particularly farming of tobacco, which also pose risk. Here we are just showing the water and sanitation coverages in the 29 wards that we talked about. We can see that we've got wards which has got very low water coverage. For example, you can see Mfurudzi, it has got a water coverage of 24 and a sanitation coverage of 37. And usually the disease, they follow this proper trajectory in terms of water and sanitation. Where there is wash stress, you discover that that is where we have most of the diseases. We've got other wards like Tafuna, where we're having problems of scabies as well, and Chisaka, which record water coverage of around 10, and also wash stress of around 35%. We also have Masau, which are also red areas. They've got a water coverage of 14%. Here we are showing schistosomiasis cases in Shamba district. I've earlier on alluded to Mfurudzi ward, which has got very low water coverage and low sanitation. Like what you can see, we've got high incidence of bilharzia. This information is for 2023. High incidence of bilharzia in males under 5 years. It is distinctively high, and we don't know why it is the males under 5s which are included. Despite the 6 rounds of mass drug administration that we have done, we can actually see that the disease is also proportionally spread in all other clinics or areas affecting all age groups, which actually presents a challenge. We have done administering of praziquantel, albendazole, but we still have these pockets of infections. We actually do not know what is actually happening in the community. This one, it shows distribution of scabies in Shamba district. You can also see that in areas where we have got wash stress, we also have the disease like Chakadzi, Gora, Mulit, where we've got Soma, which has got low coverage of water and sanitation. So the risk factors for NTDs, usually there's poverty, particularly in Shamba. People scrounge for gold, doing artisanal mining. They go in areas where water is scarce and also where there are no toilets in search of gold. And they will prioritize gold panning over anything. We also have a high mosquito density. Of course, we also do IRS, indoor residual house spraying, but there is usually high mosquito density and proximity again to the game park. So we also have diseases such as sleeping sickness, which have been reported in areas such as Mfuri. High mobility due to gold panning also puts the community at risk. We also have poor treatment seeking behaviors in terms of perceived risk. That is for the communities to look for treatment early, albeit the presence of low water and low water sanitation, and also lack of information. Hence, there is poor risk perception. Inadequate diagnostic capacity and services, together with case management, compromises our surveillance on NTDs. Like sometimes we have to scrounge for information with regards to how this disease is actually spread in the community. In terms of diagnosis, in terms of the case definition, yes, of course, we've got the ADLIs, but it's still a challenge in diagnosis to actually know the particular NTDs. I think we had one nurse who talked about the need for RDTs. So hence, the information might be difficult to get, even for schistosomiasis, to distinguish S. mansoni from S. hematobium. Usually, we are just basing on terminal hematuria, and we base on what the patient is telling us. So it's actually difficult to know how widespread the disease is. We've tried to do a prevalence study where even in the community, the disease is pronounced in people who are at home, who are not perceiving themselves as being sick. Challenges by the affected, social exclusion along cultural lines, where they are said to be having ill luck, self-isolation. Some people develop the disease. I think you have heard their experiences, and also stigma and marginalization on community programs. Compromising security. There's also affects affected. Access to to terrain and also knowledge gap on healthcare providers. Like we said, we've got a lot of entities. I can give, like, for example, of trachoma. Usually, they're just eye infections. But to actually distinguish whether it's trachoma might be a challenge. And also for diseases such as schistosomiasis. Hence, to actually define how widespread the disease is in the community might present with challenges. In terms of poor access to medical services upon diagnosis, if a person is diagnosed, let's say, with NTDs, in terms of continuation with treatment, it's different. I'll give you an example with malaria or TB or HIV. In such programs, the referral pattern is actually distinct. The person, and also there is issues to do with financing of these programs. But with NTDs, it is different in terms of how they are managed. So maybe if it was pronounced like it is for malaria and TB or other programs, it would be plausible. Then no proper wash. Usually, people who are affected, they continue staying in environments with poor water and sanitation coverage. Interventions, we've had partners who engage in activities such as borehole drilling, promoting hygiene in communities. But although most of these boreholes, they break down, and issues to do with maintenance is a challenge. Mechanized agriculture and risk communication. Those who are in agricultural activities, there's also need for risk communication for them to uptake preventive measures. Like, for example, preventing themselves from contracting schistosomiasis. There is need for policy change and advocacy, maybe through leadership, like I only talked about the need for technical input to actually have the NTDs program also having the attention they really deserve. Like I've said, they are usually overlooked. Improve on risk communication and community engagement. That is dialogue meetings, FGDs, in-depth interviews, operational research. We are in the process of trying to do a social inquiry, a qualitative study, where we want to see, where we want to co-design interventions with the community, taking them into cognizance, to spend time with them and have an empathetical approach. Like when we are designing interventions, the community, they have to be involved in how they want the decision to be made. So we are working together with Professor Mtuluzi on enhancement of community engagement to devise a human-centered design, human-centered approach to come up with interventions to eliminate schistosomiasis. Vector control is also important, but it's not being done. It is also important to differentiate the different vectors which are responsible for transmission of these diseases. Like, for example, for bilharzia or schistosomiasis, snail control speciation is very important to differentiate maybe the Venus species, and also biofilaria feiferi. It's very important as basis for control, so that we know whether a person is having S. mansoni or S. hematobium, depending on the species. So it's important to control this in the environment. rehabilitation activities for those affected is also important for social support to actually give support to those who are affected. Active case finding is also important, maybe capacitating the community and the village health workers to identify these cases early. It's important to initiate treatment in the first stages of infection rather than trying to seek treatment when the conditions are actually deteriorating. Surveillance system, it's also a challenge where we talked about diagnosis and reporting early treatment. Trying to identify, like we've talked about, the knowledge gap in trying to identify all the entities that we talked about, and also reporting on those ones. So the information that we might have might not be complete. We've talked about vector control and also continuous treatment, funding, lack of knowledge, poor treatment seeking behavior. It's important to impart knowledge to the community so that they have a perceived risk. If the community know that they are likely to have a particular condition, and also they understand the severity and also the debilitating condition of a disease, they are likely to take a positive behavior change. So it's very important to engage the community so that we avoid myths, customs, and beliefs which can come up as barriers in accessing treatment and coming for treatment early, and also avoid stigma. On policy issues, a multifaceted approach is therefore required, focusing on prevention, treatment, research, and community engagement. Prevention involves implementing strategies such as vector control, improved access to clean water, sanitation and hygiene practices, and health education. So if we target the root causes of these diseases, prevention efforts can significantly reduce the burden of entities. For instance, providing access to clean water and promoting good hygiene practices can prevent spread of diseases like bilharzia and trachoma. Treatment and management policies. Equally important is the availability of effective treatment for those already affected by entities, but there is no quite clear policy on how the treatment is supposed to go. Continuation of treatment, and also the visits, the domicile visits, to assess and also understand how the community, those affected are living after they've been diagnosed of the disease. Access to affordable and quality healthcare services. Like we said, the disease is prevalent in those who are living in excruciating poverty, including diagnosis and treatment, is crucial in line with the universal health coverage goal. Additionally, healthcare systems need to be strengthened to provide comprehensive healthcare support for individuals affected by entities. But this will start with advocacy, sensitization of policymakers, particularly on equity. We are saying that if a person is staying in rural areas and those who are staying maybe in urban areas, their access to treatment, it has to be the same, because those who are at a better in rural then governments to provide leadership and commitment to the achievement of the goal in national targets. Community engagement plays a pivotal role in addressing entities. The communities must be empowered actively. This can be achieved through education, awareness campaign, community-based intervention, the participation of local leaders and volunteers. By engaging communities, interventions can be tailored to their specific needs and cultural practices. We've talked about challenges at Rural Health Center, but we also have many competing programs in terms of maybe diagnosis, like the index of suspicion. And at times there is a burnout, issues to do with incentives, exodus of staff for greener pastures. Sometimes we run out of medicines. However, a routine supply finds out, and mobility of environmental health technicians. I think my time is up to Dave, but that was the last slide. Thank you very much.
Thank you very much for giving us a presentation on the experiences at Shamvadi. And I would like to welcome two comments or questions. Just two.
So, interpretation in Shona, saka vadanda jena vatsanangudza kuchitika panyaya yekutowedzera haisi kudzokera kumashure, uye inobva yabatana nekorera muShamva district mavanoshandira, ichibva yakonzeresa urombo hwakanyanya, kurwara nekuremara. Nzvimbo dzakanyanya kuwanda chirwere ichi inonzi chevakadzi nemufurudzi, uye fanana neSudani vanakomana ndo vanonyanya kubatwa nechirwere ichi, hameno kuti nemhaka yei. Zvinoita kuti korera chirwere ichi chinyanye kuwanda katikati marisk factors. Urombo hunokonzera kuti vanhu vagare murwizi vachida kuunga, kunonzi kuita sekuunga, ndizvo kuunga goridhe. Then kune mosquito dzakawanda, mutu unoruma zvisingaiti ikoko, nekugara padhuze negame park, umufurudzi game park riya. Kozotiwo vanhu havadi kurapwa, vanoda kuenda kunana madzibaba kana vakarwara, ndozvimwe zvataurwa panapa. Vanhu vanoafektwa nezvirwere izvi vari kunyanya kusangana nekusarudzwa, atingati social exclusion, kusiiwa pazvirongwa zvebudiriro zvedunhu kana zvenyika, kushayiwa chikafu, kuve nekuoma kuti vakwanise kusvika pazvipatara, nezvipatara zviri kure nakure. Vanovawo vasinawo zvatingati washi, mvura yakachena nezvimbuzi zvekuseenzesa. Kozoti muhealth sector macho manesi ari kunzi haana kunyatsokudzidziswa kuti vanobata sei vanhu vane zvirwere izvi, uye dzonguva vanotadza kuita diagnosis. Kunozoitawo nyaya yezvitendero. Vamwe vanofunga kuti zviri kukonzerwa nemadhimoni kana zvichingodaro. Pari kuda paitwe tingati mainterventions zvatinhu zviri kugadziriswa, kugadzira nyaya yemvura yakachena nezvimbuzi, kugeza maoko nekugeza kumeso, kuzama kuita kuti kudiridzira magadheni kuitwe nemasprinkler kuitira kuti vanhu varege kubata mvura, nekukurudzira vanhu kuti vachinje maitire avo pakufunga nepakubatwa nezvirwere zvatingati behavior change. Saka ndizvo zvinhu zvataurwa in short. Moziva kuti nguva yapera, saka hatichakwanisi kutsanangudza zvese zvese, asi tikati ndizvo zvataurwa izvozvo mazviri.
Nitakwenda kuongea kidogo kwa kifupi alichoongea kwamba alikuwa alikuwa anaelezea kwa kifupi kuhusu Zimbabwe na magonjwa ambayo hayapewi kipaumbele, kwamba Zimbabwe imeathirika na magonjwa haya ya NTD, na pia ameelezea changamoto zinazowakabili wale wote ambao wameathirika na magonjwa haya ambayo hayapewi kipaumbele. Lakini ameongelea namna gani tunaweza kuintervene, kuingilia kati ili hawa watu ambao wameathirika waweze kupata msaada, ambao ni kama tunaweza tukafanya kuwatafuta hawa watu ambao wameathirika katika maeneo yao, lakini pia tunaweza tukafanya vector control kwa ajili ya kama ile konokono kwenda kuwatafuta na kuweza kuwa control ili wasiendelee kusambaza maambukizi ya kichocho. Lakini pia kuna mambo ya advocacy na pia kuimprove on risk kwenye communication. Lakini pia ameongelea namna gani kichocho kinaweza kuwa au magonjwa ambayo hayapewi kipaumbele, kwamba yanaweza kupatiwa matibabu na pia kuwa managed, lakini kwa kupitia policies, watengeneza policies ambazo zitaelezea haya mambo. Lakini pia ameongelea kwa kifupi kuhusu mambo ya community program, yani zile program ambazo ziko kwenye ngazi ya jamii. Lakini pia ameelezea challenges, changamoto ambazo wanakabiliana nazo kwenye vituo vya afya, na pia aliongea akasema ni njia gani au policy ipi ambazo zinaweza zikasaidia ili kuweza kukabiliana na haya magonjwa yaliyokuwa hayapewi kipaumbele, kama kufanya uhamasishaji kwa viongozi wa jamii katika yale maeneo ambayo tayari yana magonjwa yaliyokuwa hayapewi kipaumbele, au kuweza kufanya tafiti tofauti tofauti katika haya maeneo ili kuweza kujua ni changamoto gani wanakabiliana nazo na kuweza kuzitafutia solution. Asante.
Thank you very much, Cecilia. And thank you very much, Godfrey, for the next presentation. And now we are going to allow room for 2 comments or questions, just 2, so that we may move to the next session.
Thank you. Sister Quint, yesterday when I asked the question of the experience of the nurses in the clinic, when you were faced with NPD patients, you promised me you're going to answer today. I hope that wasn't your answer, so I'm going to pass the mic on to you so you can answer that question, because this is very important. If I might let my other Shona speakers know, Sister Kwenda nezuro vakanzvenga mubvunzo vanakusangana nemubvunzo wandakavabvunza kuti sister, kana muchitarisana nepatient nemunhu anorwara any of these ma-NTDs, whether iri chirwere chechipfungwa, LF, imimi sanesi, patient yauya pamberi penyu, ndaapi madambudziko amunosangana nawo? Havasati vandipindura, saka ndiri kukumbira kuti vochisangana nemubvunzo wangu izvozvi so.
Thank you very much for repeating the question. I think it has been alluded somewhere in the presentation. And now I'm going to answer you. The challenges we are facing is that when the patient comes, presentations, that's the signs and symptoms, there are other diseases that have got the signs and symptoms that are same with the LF, like malaria,
a patient comes in with a high fever, headaches, muscle pain, and we test for malaria. Malaria becomes positive. Then we manage for malaria, leaving LF. So when the client comes, whenever she comes or whenever he comes again for reviews, the patient continues to have malaria. So we might say this patient is being infected with malaria many times. And we educate that client on prevention strategies. But the patient has been already infected with LF. We don't have diagnostic tests for LF. If it was possible, whenever a client comes for treatment and has got the signs and symptoms of malaria, the patient should also be tested for LF. Maybe we might diagnose LF as early as possible. Now we are diagnosing LF late in complications, patient already in complications, patient already with disabilities, and being affected already, being poor because of frequency visiting of facilities. Also with the schistosomiasis, we have got the challenge, I was thinking in the lines of abdominal distensions and upper gastric bleeding. I was associating that we might be missing other patients in Zimbabwe because we are diagnosing upper gastric bleeding with associating with the gastric ulcers. And you are treating for gastric ulcers, not for bilharzia, and not even bothering to test for bilharzia. So we need also the diagnostic tests for bilharzia that are also related to abdominal distension and upper gastric bleeding, so that we might not miss. We are just saying this patient might have ascites, portal hypertension, and we really diagnose the portal hypertension, but the cause might be missed. Also, on schistosomiasis, cystosoma mansoni, cystosoma hematobium, there are all other conditions that are associated with the cystosoma hematobium. The patient might have other diseases that are related to that. They might present with anemia, but missing the cystosoma hematobium. They might present with kidney diseases, complaining of backache, complaining of other conditions. And we are also missing a cystosoma hematobium. With the cystosoma again, mass drug administration is focused on 5 to 15 years. So 5 to 15 years children have been given mass drug administration many rounds, but the below 5 years and the above, they've been missed. And I think there is a reinfection circulating in our country because we are not treating all the entire population as what was done with the LF. But with the LF, it seems there are other pockets that are coming out in the district of new infections. So I think there is also need to have another round of MDA of LF and the rounds of MDA to the entire population of Shamba district, as it is the one of the highest district with the infected clients with schistosomiasis. We also need diagnostic, I think, training for the healthcare workers to do what we call supermarket approach when diagnosing the clients, and also be able to have signs and symptoms that have got diseases that shows the same trend. So we need to be trained on that so that we might not miss our clients. Then on the issue again of medicines, we don't have enough medicines for the treatment. I think last year we've got stock out of praziquantel and also stock out of albendazole, which might cause health hazards and reinfections. The community itself has got a challenge. They report late to the facility, and the community of Shamba is mostly of religious beliefs that do not go to the facility as early as possible. They start to seek health care from the prophets and from the traditional healers. So when they come to the facilities, they will be already in complicated cases. So we need a high advocates meetings with the policymakers so that when they talk about health, they also talk about the Public Health Act, so that especially for the children, not to be missed. And for the rights of the children, they should be considered in the treatment of these children, so that they will not refuse with their children. I think I've done justice to you. Thank you.
You have, sister. So what I'm going to do, so people know that I have learned and passed my exam, I'm going to interpret what you said in Shona.
Thank you.
Okay. So very quickly in Shona, ndabvunza sister wasangana nemubvunzo wangu, saka kuti vazive kuti ndagwaza pazama ravandipa ndakuchiedzawo kutaura muchishona. Sister wataura zvinhu zvakakosha. Vataura kuti munhu akauya muchipatara ane fever, ari kupisa miri, nomutesta toona kuti ane malaria, tomurapa malaria. Patiri pari zvino hatikwanise kunge tichimutesta pezvinhu zvakawanda, saka anoramba achidzoka tichirapa malaria. Iye munhu ane lymphatic filariasis. Saka lymphatic filariasis hatisi kuiona ndekuti tiri kutsvaga chinhu chimwe nechimwe nechimwe. Vati tinovabatsira kuita basa ravo kunge tine zvekuvaongorora, tichiongorora zvirwere zvakawanda panguva imwe chete, kuitira kuti kana tikabata malaria hatizoposa zvimwe zviripo. Ichi chinhu chakakosha chaizvo, chinhu chakakosha kwandiri ndekuti isusu tiri kutoedzawo kuti tuwane zvatingashandise kuti kana munhu akauya tikatora ropa padiki diki nekubaya pachigumwe pavo paya paya, tinogona kutarisa zvirwere kana 10 panguva imwe chete. Chinhu chandinoona kuti chingakubatsirei ana sister. Saka zvamatotaura kudaro zvatondibatsirawo inini. Matipa manyawi ekuti tienderera mberi tichitarisa ipapo. Vataura futi kuti pane vanhu vanouya vachirutsa ropa muZimbabwe, tanga tiri kungofunga vane zvironda mumatumbu, tanga tisiri kutarisira kuti pamwe vane chirwere chebharazia remudumbu rinenge richivaitisa kuti varutse. Saka zvautori pano so vatodzidzawo kune vamwe vedu vekuTanzania kuti zvinhu zvinoitika. Vataurazve chimwe chinhu chakakosha chekutaura kuti patiri kurapa tichipa mishonga yebharazia, tinopa vana vane makore 5 kusvika 15. Tiri kusiya vana tudiki tunenge tune makore ari pasi pe5 nevakuru vasiri muchikoro. Izvi zviri kuita kuti chirwere chirambe chichitenderera, ndekuti vana vadiki ava vanenge vakatichengeta, vakuru vanenge vakachitendera. Imwewo futi nyaya yatiri kutaura kuti kana tichiti ngatiendei kunorapa dunhu rese, ngatitangirei pavana vane makore 2, toenda pane vana vari kuchikoro, tozoenda futi kuvadzimai nana baba vakuru. Vataura kuti chinhu chakakosha ichocho, apo tinonzwanana ndekuti ndizvo zvimwe zvatanga tichida kunyatsoona kuti varidzi vecommunity ndo zvavari kuda here, kuitira kuti tione kuti tinogonawo kunoita ruzha kune vanokwanisa kutibatsira kuti tione kuti mishonga yese yapinda kunana nesi wedu. Right? vataura futi kuti panyaya yekuti vanenge vachida kuona zvirwere zvakawanda kamwe chete ngavadzidziswe kuitira kuti itove paunodzidziswa kuti munochengeta murwere wenyu chakadai so kana kuti munauya kuzoonekwa kuchipatara vagare vakaziva kuti tinofanirwa kuita zvakadai sei zvakadai sei zvakadai so ndekuti tadzidziswa mishonga vati vatoda mushonga tisinogona kutaura kuti hapana chinhu chakaipa sekuti munhu anouya kuchipatara oti ndiri kurwara sista vomutaura kuti ezveshuwa uri kurwara nechakati asi hapana mabatsiro andinokuita ndekuti handina mushonga wacho saka vari kuda kubviswa pakondisheni yekuti vanenge vachidaro kune client yakuti hatina mushonga vari kuda mushonga and then sista vataura kutoda kutopopota kuti izvona tinenge tichida kuti panyaya yevana vana vabereki vanoenda kuchechi bvume kurapwa vari vana vadiki Public Health Act pane murau wehuman rights unotaura kuti mwana ngaarapwe saka kana vabereki vachiramba kurapisa mwana vanofanirwa kunge vachitaurirwa kudai so ende vakuru vavo vatungamiriri vedu vanofanirwa kutaura kukosha kwakaita Public Health Act for Children. Ndagona here sister?
Nitakwenda kusummarize. Profesa Mtapi alimuuliza dada kuhusu challenges ambazo wanaweza kukabiliana nazo wanapokuwa kwenye kituo cha afya. Changamoto ambazo wanakabiliana nazo kwenye kituo cha afya. Anasema changamoto hizo kwamba wagonjwa wanapokwenda pale mara nyingi huwa wana test positive, wakipima magonjwa wanakutwa na malaria. Kwa hiyo huwa wanawapa dawa kuweza kuwatibu ugonjwa wa malaria. Lakini pia akasema kwenye vile vituo vya afya hawana zile vifaa vya kupimia kuweza kutambua kama huyu mtu anaumwa ugonjwa wa matende au anaumwa ugonjwa wa kichocho. Sasa wanaishia kwenda kutibu yale magonjwa ambayo yako associated, yanayohusiana na yale magonjwa. Lakini pia akasema hakuna dawa za kutosha kwa ajili ya kutibu. Kwa hiyo lakini pia wagonjwa huwa wanachelewa kwenda kwenye kituo cha afya. Wanakwenda tayari wameshaathirika kwa kiwango kikubwa. Lakini pale aliposema kwamba wanaishia kutibu yale magonjwa ambayo yako associated na haya magonjwa, wanaporudi kule kwenye jamii yale maambukizi kunakuwa na reinfection, maambukizi yanaendelea kutokea. Asante.
Thank you very much. We are running out of time, so I would like to welcome Dr. Shahari Ahmed to give us a presentation of the experience of Zanzibar's NTP program.
Habari za asubuhi jamani. Good morning everyone. I'm going to give you an update of what we've been doing when it comes to as have been introduced. My name is Ali Ahmed, and I'm currently Neglected Tropical Disease Program Manager for Zanzibar. So Zanzibar is endemic for NTD as well, and we have not very many, but we have urogenital schistosomiasis, we have lymphatic filariasis, we have soil-transmitted helminth, of course we have snake bites, trachoma in only few areas of Zanzibar, especially in Visiwani district, and few pockets in Kaskazini A district, and we have fungiasis. But schistosomiasis, soil-transmitted helminth, and lymphatic filariasis, these are the common ones which you can see almost everywhere in Zanzibar. Of course, there will be some, most likely we can elaborate further. So when you look on the distribution of these infections, which I've just mentioned, schistosoma hematobium, which is causing urogenital schistosomiasis, is almost confined to only areas where there are surface water, abundant surface water, and snails, of course. So those two things have to go together. So there are some areas in Zanzibar where there's no local transmission of schistosomiasis for the reason I've mentioned. And soil transmitted is widely distributed all over in islands. LF is well distributed elsewhere, but more common in South District compared to other districts of Zanzibar. So there is variation of these infections between and within islands. If you look between Unguja and Pemba, the main two islands of Zanzibar, there are more cases of schistosomiasis in Pemba rather than Unguja. Similarly, there are so many cases of soil-transmitted helminth in Pemba rather than Unguja, and but there are more cases of lymphatic filariasis in Unguja compared to Pemba. So there are some differences, and this is because of the ecological differences between the two areas as well. So when it comes to control activities, firstly, our program has been evolved over time. In the early years, when the program was started, it started as the helminth control program was independent, and so there were vertical programs for soil-transmitted helminth, for schistosomiasis, and for lymphatic filariasis. But over the years, then those three programs have been integrated together, and now we have one program, which is the Neglected Tropical Disease Program, which is dealing with all those entities. So our main activities, or in terms of intervention we have been doing over the years, is preventive chemotherapy, just as other countries have been done. And so we are using, for soil-transmitted, we are using albendazole and sometimes mebendazole, depending on the availability. And for LF, we are using ivermectin and albendazole. For schisto, we are using and in those areas where there are trachomas, we are using azithromycin to distribute in those communities. So here is a map of Pemba, which shows some of the findings we got between 2012 to 2018. Because we had a project called SCO, and that was Schistosomiasis Consortium. And our main objective for that was to look for the feasibility of eliminating schistosomiasis in Zanzibar. And that was like an example. If Zanzibar can eliminate schistosomiasis, of course, some other countries may eliminate too. So we had a 5-year project, which started in 2012. So if you look at the Pemba map, you can see there are so many areas with red dots, which indicating there was a high transmission of around 15%. Some other areas, of course, they were less than that. So, but by 2018, when we are almost finishing the project, you can see now the red dots has been reduced, meaning that the prevalence of schistosomiasis in those areas was reduced. So, And this is the map of Pemba, map of Unguja. So there was a similar cases. So for Unguja, the schistosomiasis is more confined in the districts of Magharibi A, Magharibi B, some Kaskazini B district, and a few areas in the Kaskazini A district, but there's no schistosomiasis in the south, here at the far south. And this is because of the reason I've mentioned earlier on. In this area, it's very coral and there's less surface water. There are only few areas which are concerning me. Of course, I will discuss this as, in some of my subsequent slides. But there are few areas, I'm saying, where there are snails, mostly Bulinus nasutas. And the biology of schistosomiasis transmission here is a little bit complicated when it comes with the snails involved in the transmission. So Unguja, particularly southern areas, is believed to have Bulinus nasutas, which are believed not implicated in the transmission of schistosomiasis in Zanzibar, in those particular areas. It's a very long story, and of course we can discuss this. But anyway, coming back to this map, you can see at the beginning of the project in 2012, there were also some red dots indicating there was high transmission of schistosomiasis in those areas. But over the years, in 2019, you can see most of the areas with with the green dots, indicating that the transmission has been somehow interrupted, and there are only few pockets where still there was high transmission, especially in some areas in Kaskazini B, particularly in Kinyasini, where there's very high transmission of schistosomiasis. So this is basically very similar to what have been said, but in a graphical form. If you look in the 2012, at the onset of the project, for the school-age children between 9 to 12 years, the prevalence was around 6, and then reduced over time, but very inconsistently. But at least at the end of the project in 2017, the infection was reduced to less than 2%, and that was similar also kind of finding for the adult population who had an age around 20 to 55 years. But now there are a few alarming issues which are bringing some questions to ask myself if there's a changing of epidemiology and potential risk of reintroduction in some areas. Because if you look on the figure, you can see in Micheweni district, there were more women with schistosomiasis, and these are the cases of schistosomiasis which reported in health facility in 2013. So you can see there were many cases of female, almost in many other areas, especially in Micheweni and Magharibi B district. So there it changes. But my big worries is where there is this arrow in South Unguja, because this area is known to have no local transmission. If you find cases now, then you have to ask yourself, what is happening there? Are these locally transmitted cases? Are these imported cases? And what will be the implication for these cases? And this is because now we made a visit a few months ago, and you can see the snails in that particular areas and the water bodies. And these snails, with my colleague, we have set an experiment. We have tried to infect these snails and compare with the other snails, and we've sent these snails to our colleagues in Natural History Museum for further analysis to find if really these snails are refractory to schistosomiasis or not. Because if you have few cases and you have snails, meaning that the transmission may go on. So we are trying to monitor what is happening in this particular area. This is in South Unguja, in Kizimkazi, and a similar case in Mtende, where this Bulinus nasutas. So when it comes to soil-transmitted helminths, as I said, the distribution is almost everywhere. But this was 2020, the last survey we did, and you can see the transmission of STH is very high. Around 8% of the school children who are involved in the study, they hate worms. And some of these, they have mixed infection. They have sometimes double or triple infection with soil-transmitted helminths. But the good thing, if you look on the right-hand side, the figure, most of those who are infected have light infection, which is okay when it comes to the program. But this is really very tricky because at WHO level, they are looking for prevalence to decide for you to continue mass drug administration. If you do it to once a year or twice a year whatsoever, they are not looking on the intensity. But when it comes to achieving a public health problem, then they are looking on the intensity. So if the intensity is low, then you can say, oh, something is good. But when it comes to transmission, something is not very good. So I can skip this. So for filaria, as I said, is distributed elsewhere or everywhere in Zanzibar, but more cases are in the southern region rather than other areas. I don't know exactly why this, but probably because there might be some more mosquitoes and behavior, but this particular area, there might be more pit latrines. You know, pit latrines are very good for breeding of Culex mosquito, which are implicated in the transmission of lymphatic filariasis. I'm not very much sure, but this is might be one of the reasons, because there are less water in this particular area, in south region, or in south district, as I mentioned earlier on. And there is the association of transmission of lymphatic filariasis with water. This is water related. But if there's less water, but there's so much transmission, what really is happening in that area? Maybe because of the pit latrines which are there, which are forming breeding sites for that. So it's common in Unguja as well to see this kind of features when it comes to lymphatic filariasis. The left one is taken from the web, but the right side picture, this is someone in this island of Unguja. He's trying to tie his lower leg with a piece of kanga, but then instead of trying to relieve the pain, but it's causing more problem because of the drainage of the fluid. So for the lymphatic filariasis, as I said earlier on, we are distributing ivermectin, and we have started the program since 2001. So for the 5 years between 2001 and 2006, and then through the surveys which was done by the time, revealed a less than 1% microfilary, and then the program stopped distribution of mass drug administration. So by 2012, then we did a TAS, a transmission assessment survey, which revealed around 3.5% of microfilary, and then the distribution of drug was resumed because of the high prevalence of microfilary. And then we did another pre-transmission assessment in October 2012, and the transmission seemed to be now going a little bit low, around less than 1%, but there are areas which have transmission of around 3% or more in some areas. So when it comes to management of morbidity for lymphatic filariasis, I have to be very honest, we are doing this, but very intermittently. So we had a support from ASEAN project in 2001, where we managed to reach many people who had lymphedema and hydrocele, and then at least 105 people who had potentially signs, or let's say, sign of hydrocele, those who had scrotal swelling, then they were screened, and those who were confirmed with hydrocele, at least 105, they were operated in 2001. So since then, we haven't done any concrete kind of intervention for the management of morbidity. So in the same year, we had training with people who have been infected, and they were trained in how to take care of themselves, as you can see from the picture. And at least by that time, around 248 individuals were trained on management of morbidity of the lymphedema, and they were supported also with the materials for that. So for trachoma, we did a baseline survey in 2015, and the prevalence of TF, the inflammation follicular, was very high in children 1 year and 1 to 9 years. It was around 11.4%, and that necessitated the introduction of mass distribution in that particular area with the erythromycin. So, but by the time in 2016, in 3-year time, when we did the survey, in the impact survey, the prevalence of trachomatous inflammation follicular went down to around 5%. And when you are reaching to that level, then you are no longer allowed to continue with mass drug administration. And then the people who had trichuriasis have been operated, and still the operation is continuing in some areas. So for us in Zanzibar, we are mainly focusing on the two elements of the strategy. Okay, we are mostly concentrating on the SNA in terms of surgery and antibiotic distribution, but the F and E component, we are a little bit struggling, but I think we'll be somewhere. So we have recently preparing the dossier for trachoma, because we have reached to the elimination of public health problem. So snake bites, which is also a problem, is mostly in Unguja. So these districts, which are on your right-hand side, from Kaskazini A to Mjini, these are the Unguja districts. So you can see there are so many cases of snake bites compared to Pemba. And many of those cases, you can find them in Magharibi B district. So our future plans is, of course, we are in lining with the mission for the WHO and our strategic plan for 2023-2027 to make sure that we are eliminating NTD. So hopefully we can reach on that. But our big challenge is we are thinking there might be some resistance with albendazole, because you have seen the prevalence of STH is very high, and we have been distributing STH albendazole since basically, you can say 1994, of course intermittently, but the drug has been out for a long time, and you can see the prevalence of STH is still very high. So we are thinking there might be some drug resistance going on here and there. Of course, there are low coverage and sometimes compliance in some areas, and we have inadequate financial resource for drug distribution. Thanks to Unlimited Health, who are supporting us. And then there's inadequate involvement of other stakeholders, especially the Water Authority. Many of the sectors think that the health problem is a responsibility of the Minister of Health, and they don't think that they have a stake on this. So this is basically what we have been doing over the year, and thank you so much for listening, for effort to change that spelling.
Thank you very much, Dr. Shari, for a very wonderful and informative presentation. And I would like to welcome Dr. Tagi for a summary.
Saka Zanzibar, Dr. Shali Ame vakamirira Zanzibar. Zanzibar ndo yatiri inoi. Vataura kuti inoi Zanzibar pane imwe inonzi Pemba, inowe island futi rimwe right. Hanzi zvirwere zviri muno muishisto so transmitted nechiya chemudumbu, chiya chatati chirwere chemakonye emudumbu chiya, kwozoita trachoma zvinoziva test. Kubva 2012 pane zvakaitwa interventions of mass drug administration nezvikaredusa zvikuru vanorwara vaiba kuwanikwa vachirwara nezvirwere izvozvizvi, kunyanya muUnguja area. Chakasiyana nedzimwe nzvimbo ndechekuti muno muUnguja area vanhukadzi ndo vaiwanikwa vachinyanya kuaffectwa kudarika vanhurume, kubva kuvanhu vakura batanza nekuvana zvakare. Zvii zvavakaita kuti vabatsire vanorwara, vakaita surgery, vakabatsirawo vashoma, asi mazuva ano yakambomira. Vakadzidzisa vanhu self care, kuzvimiririra, kudzidzisa vanhu kugeza maronda kana aripo, vane makumbo akazvimba vaya kuti rinogezwa sei, nekuvapa zvokusenzesa pakugeza kwacho. Munguja area makare imomo muri kuwanikwawo zvakare muchiita snake bites, kurumwa nenyoka. Havana kuzotaura kuti nyoka dzacho itype dzipi, asi vati kurumwa nenyoka kwakawanda kudarika kune rimwe dunhu rinonzi Pemba. Zvii zviri kunetsa, hanzi tiri kuwana kuti pane drug resistance. Mishonga yavaisenzesa inenge isanyatsi kushanda nekuti zvaakuita kuti vanhu vanorwara varambe vachiita sekuwanda. Pane kushayikwa kwemishonga senyika iri kubudirirawo sekangofananawo neyedu. Kune kushayikwa kwemari yekusenzesa, uye kune kushayikwa kwebatira pamwe nemamwe mabazi ehurumende anofanirwa vachisapota. Ndikati in short ndizvozvo. Mazvita. Thank you.
Nitaongea kwa kifupi sana alichokuwa anaongea Dr. Shahali. Dr. Shahali ameongelea kwa kifupi kuhusu magonjwa yalikuwa yapewa kipaumbele kwa upande wa Zanzibar, na akasema kichocho kwa Zanzibar, kwa upande wa Unguja hakuna. Akasema minyoo ya tumbo iko kwa Zanzibar, watu wameathirika, lakini pia LF ni changamoto, na kuna wagonjwa wengi walioathirika kwa upande wa South Unguja Kusini. Lakini pia akasema kazi zinazofanyika kwa namna ya kuweza kuzuia haya magonjwa, kwamba kuna ugawaji wa dawa ambapo kwa upande wa STH, kwa upande wa minyoo ya tumbo wanagawa dawa aina ya albendazole na mebendazole. Kwa upande wa LF, ugonjwa wa matende na mabusha, wanagawa dawa ya albendazole na ivermectin. Lakini pia kwa trachoma wanagawa dawa ya azithromycin. Akasema kichocho kwa upande wa Zanzibar kiliisha mwaka 2017, ambapo kiweza kuonekana kwamba maambukizi yanaendelea kupungua. Lakini pia akasema kwa sasa kwa mwaka 2023, mwaka jana, kuna watu ambao wamegundulika au wamekuwa wakienda kuripoti kwenye vituo vya afya. Kwa hiyo ikaonyesha kwamba kichocho bado kuna changamoto, lakini pia wakaenda wakafanya research kwenye eneo la South Unguja Kizimkazi, wakakutana na konokono snail habitat, ambapo wameamua kumpima na wanaendelea kuangalia kama ana maambukizi ambayo yanaweza yakaambukiza ugonjwa wa kichocho, na wanaendelea kumonitor, wanaendelea kuangalia. Ugonjwa wa minyoo ya tumbo kwa Zanzibar, kuna study nayo ilifanyika mwaka 2020 na ikaonekana maambukizi yako kidogo. Upande wa matende na mabusha kwa Zanzibar bado ni tatizo kwa upande wa South Unguja Kusini, ambapo mwaka 2012 mpaka mwaka 2019 ilionekana pia ugonjwa huu unaendelea kupungua. Asante.
Thank you very much. And now I'm going to welcome only one question or comment. Burning question or comment. So that we may proceed with the other presentation. Anyone?
Dr. Shali, you said something that was very intriguing for me. We encourage people to have pit latrines so that we do away with infection. And here is a situation that seems contradictory, where the pit latrine is actually becoming an incubator for infection. How then do we deal with the built environment as a way of taking away infection? Your example on, I found very, not confusing, but it just messed up the way that I normally think about interventions.
It's a very interesting question. Actually, everything, most of the things, if not everything we are doing, there might be two sides, like a coin. There's a tail and head. So let us look back on the breeding site for Culex mosquitoes. They love areas which are, or like water which is biologically polluted, right? So if you have a pit latrine, even if you are trying to close it, try to open it more. You see a bunch of mosquitoes coming out from your latrine. But of course, from the other side of the coin, these are the cheaper ones, cheaper kind of toilets, and you are trying to, you have to avoid open defecation, so you have to use the, even no technology to build your latrine. But then the other side, this is what we are seeing in most areas. There are so much Culex mosquito coming out from this. So probably what you can do, you can open and put even oil. If you put oil, or if you put kerosene, then will help in terms of reducing mosquito population, because that will form layer and the mosquito breeding will be minimized. So we need to encourage people to construct those kind of latrine, but there are additional measures they have to take to reduce mosquito population.
I was saying in other communities, the ash that they collect from the fire, they then actually spread it over the surface of the pit latrine. It also helps. So these are cost-effective measures that you can actually do to reduce breeding of mosquitoes.
Sorry, I also have a question to Dr. Shali. You mentioned that you did a lymphedema management activities. I would like to know, is there any mechanism or any plan for the follow-up for those patients which you did the lymphedema management? And also, is government of Zanzibar has any plan for these activities or?
Not work. Is it work? Can you hear me? When you said, you mentioned pit latrines, I quickly thought about, are we thinking of Purex only, or other species might also be involved in the transmission? Because for malaria,
evidence are increasing, showing that it's not only anopheles. Other species are also carrying parasites. Or I don't know whether parasites or spores, whichever way you call them. So probably you may need to engage entomologists to give you some proof. Number two, use biolabicide, brother. Use biolabicide. Just see if the government can. I know partners won't be giving you money to buy biolabicide with the Cuban technology. Americans are in control. So we have to ask our own government to invest and then see if that will help to reduce the transmission. And the third one is just provoking thinking, not for you, for all of us. Recently, I was trying to find literature on the prevalence of whipworms. So reading, yes. And then we realized that in the areas where schisto is highly prevalent, whipworms are on the law. So is there a way we can innovatively think about the biological strategies to control some of these diseases? Just food for thought. We are still writing a proposal for whipworms. Thank
you. One was about the plan for follow-up of those who had lymphodemas, and the government if plans for those activities. I have to be honest, because not because I'm new to the program, but from my experience, those people have not been followed up since that intervention has been done, to look on the progress and if they are continuing with managing lymphedema or not. That is very unfortunate. But when it comes to the government plan, which is the program, we have a plan, and we are hoping to get some fund from End Fund. We have submitted our request, and there's an indication that they can support us on that area. So we'll reach those who have lymphedema and hydrocele, and we'll do as has been done previously in terms of training and supporting material if it will be possible, and also doing the operation for those who we will have hydrocele. That's what we are planning. And when it comes to the additional thought for mosquito, of course there are other species of mosquito which are involved in this, especially Anopheles. These Anopheles which are transmitting malaria, they can also transmit filaria worms. But from the theoretical aspect, Anopheles, mostly you can find them in rural, and Culex you can find them in urban, in that area. So if you look on, for example, Kusini Unguja, of course, is a rural area, and with less water, right? With less water, the annual rainfall in that particular place is very low, except for this year where we had the rain since on October. So, but then you're asking yourself where these breeding sites are coming from, right? So, of course, I'm agreeing with you, other species, Anopheles in particular, are implicated, but then there might be other questions. Of course, we have a big problem when it comes to entomological activity for LF. We are relying with what malaria control program is doing. But I think this is common to many of the countries. It's not only for Zanzibar. And sometimes even WHO is a little bit reluctant, and you may not find many supporters who may help you in entomological activity, especially killing mosquito which are not related to malaria. On the bio-larviciding, I'm taking your idea, and of course, if we can go to also this polystyrene beads, can also help in those pit latrines. You can have, polystyrene beads, so you can boil those and put into the pit, and that will help in reducing mosquito population.
Okay, is it me? first one is just a comment, and then I'll ask about something for all of us as food for thought. The first one is the pit latrine. You know, it was designed by scientists from Zimbabwe. They named it not Tony Blair latrine. It was once called Blair latrine. It's designed by the scientists from Zimbabwe. And the Blair latrine is designed in such a way that whatever goes inside the pit, when it is the fly, gets killed, because when it tries to come out, nicely designed so that flies will never come out. I don't know about mosquitoes, but I think for flies it was well constructed to take care of the flies. So I don't. Nowadays, it was a very good intervention, especially where waste management was a problem, where there's no reticulated sewage pipes. But now it's rampant in urban areas. What is required is to have a proper design of that waste disposal using the latrine or the Blair terrace. Then the other one is on support for your program. Because I noticed from 2001 to 2006, there was a huge reduction for some of those entities. But then they start surging. Well, you were citing partners. What is the government doing? Because, the program, whoever was giving you the support, yes, it made an impact. You can see the change. But thereafter, where is the policy? Which means if someone is coming to assist us, for all of us who are involved in, driving this program, something has come in our district or in our country. We support it. It shows a marked difference, improvement, that intervention. Thereafter, we fall back and, what are we doing? Because I know about the program here in Zanzibar. It has been doing very well. If we don't take advantage of it and sell the benefits to the government so that a policy is made, so that support can come, just like the way they are building roads, or they want to build a bridge from Zanzibar to Dar es Salaam, they should also do something as far as what is happening. Thank you.
Thank you very much. I was a little bit concerned with the issue of pit latrine. Like somebody was talking about putting the ashes inside, putting the oil. But I think the good idea is nowadays people are not building the pit latrine like you put a sheet direct so that when you come in, you see the mosquito, whatever the flies inside. The good idea is like you have a hole outside the building. Like you have a small building like a toilet, and inside you just, if you cannot afford buying the toilets like from the shop, you can just put a hole going, which will put the sheet going outside. There are no connection. So it's not easy to find like the mosquitoes coming, or you don't see the hole. It's not directly. You get in, you put your thing, they are going straight outside, the hole is outside. No need of covering, no need of, and the outside you just put a pipe for the ventilation. That's how they build it for the cheapest, those who cannot afford building the...
There are two comments and one small question. Thanks for those comments. As you have been said, this is for all of us. But specifically to go to the question of government support, I think this is also common to many of our governments. But thank the government of United Republic of Tanzania has recently announced, that's the pledge actually, after the Kigali declaration, and Mama said she will provide $3 million to support NTD in Tanzania. So within our from our side, on the Minister of Health, we are trying to digest how we can get that money, because this is for United Republic of Tanzania, for Zanzibar, and as well for mainland. So we need to see how we can get that money. So we are working on it. But of course, domestic resources is one of the problems in most of our African countries where NTDs are endemic. And this is one of the things which is now pushed, because there might be some donor fatigue. Most of our activities are relying on them, and now they're saying they're trying to pull out a little bit, and they're emphasizing on domestic resources. So this is also common to many of our countries. But yeah, we'll see what will be happening over the years. And thanks, Dr. for the comment and suggestion actually on the improvement of these pit latrines to reduce mosquito population and other nuisance things may come out from the toilets. Thank you very much, all of you, for your contributions. Asante sana.
Thank you very much, Dr. Shari. Indeed, it was a very great discussion. So before ending up with the discussion, we'll have one last presentation for this session from Dr. Mandara, and we'll be having a presentation on experiences of mainland Tanzania in managing NTD morbidities, specifically lymphatic filariasis. Dr. Mandara.
Good afternoon. Good afternoon. Are you hungry? Okay. Okay, on behalf of Dr. Faraja Lemuya, who was supposed to be with us from the Ministry of Health, working with the National Program for Neglected Tropical Diseases, she got an emergency, family matter of which was not able to come. So we stand on behalf of her, on behalf of the program, and on behalf of the ministry. So we are going to share our experience from the mainland on how we manage NTDs, morbidities for lymphatic filariasis. So far, we have done mapping since 2014, 2015, and actually we started mapping way back in 1980 to 2024, where we mapped the whole country in mainland. And then for remapping, we did that one in 2014 to 2015. And the endemic country councils or the districts are 119. And still we require to continue to do mass drug administration in 7 implementation units, in 7 councils, which are now left from 119, and now we are left with 7 councils. The population at risk is 31 million, and we have now the gap of 1.2 million who require MDA. The second target for LF elimination as a public health problem is to alleviate the suffering by managing morbidity and preventing disability. The way we combat lymphatic filariasis has 2 ways. One way is to interrupt the transmission from one person to the other, and the other arm is to do the alleviate suffering from the patient. So this requires provision of care in all areas known to have patients by 100% geographical coverage. Priority councils, we estimate in morbidity management and disability prevention, we have the areas with high councils, which are 54, and the numbers is about 29,966, and the lymphedema is about 11,000. We have the councils with a medium burden, which is 12, and the hydrocele is about 1,238, and the lymphedema patients we have in the medium councils is about 384. We have the districts with low burden, which has 53, and 53, which is 53. For the hydrocele is 1,200, and for the lymphedema is 445. So in total, if you sum up the 5412, you come up with a 199 councils with a burden of hydrocele of 32,434, and the lymphedema of 12,734. That's why we said we have to, with the mapping, the coverage should be 100 geographical coverage. And this is the map where you can see the burden. For instance, on the coast area, that's where it's a heavy burden regions or councils compared to the middle and to the least. So the methods that used to estimate the burden is by mapping. We have already mapped 7 districts. And the other way of getting this data of how the magnitude we have in the country, in the mainland, we do survey data. It's through the survey data whereby we nested a programmatic survey where once we are doing coverage evaluation survey, we do also asking questions, how many patients do they have at the district council? And while also we are doing onchocerciasis evaluation mapping, we also posted some questions asking, in this particular district, you are suffering with onco. Can you tell us how many patients do you have at your district level? And also through the pre-transmission assessment survey, where we want to see the magnitude of the disease of LF in these districts. So we also nested the questionnaire of of how many patients do they have, how many hydrocele do they have, how many lymphedema do they have. That's an opportunities we have been using it. So also through the prevalence data in relation to the areas with mapping, so you can see through those methods up to upland region endemic areas for LF, you can see also we have been getting some data. For mapping, we have 7 councils. For survey data, we got 12 districts, and through nesting questionnaire, we want to get the data, 36, prevalence data, 16. So at the end of the day, we got the data through these 6 methods we used. So the hydrocele number of patients operated so far is about 11,228. This number, we got it through camps. We performed surgeries. We combat this hydrocele burden by doing hydrocele camps, whereby in each camp, we had probably estimation of 200 patients at one time. So what we do under the Ministry of Health, we team up with the other stakeholders, technical people from the university, Muhimbili University, and the NIMRI, and the ministry itself, the program, and the resources obtained. We use it to operate about 200 in 2 weeks' time. So patients are welcomed at the camp, and they get these services free of charge because already it has been paid by the government. So once we get resources, we combat that through that way. So through camps, we have managed to operate about 10,020 people, and through these operations, we have been training health facilities, of which is about 1,208. So still we have the backlog of 21,206. This is not fixed, but it might change, because once we do the operations, once we do, we offer our services to our people, they do get encouraged that, okay, it is possible. So they come up, they show up, and that's why it's not fixed. That's why it might increase, because they have seen patients or people who have been suffering, probably having hydrocele with 40 kilograms, and the person is being operated and is coming back to the community. That means it gives them hope that the team from the Ministry of Health is doing something great for them. So you can see the burden and the surgeries that has been happening. It has been mostly implemented in the coast area. If you could remember, the burden also is on the eastern part of Tanzania mainland. So this is the team of surgeons. The middle one is the professor, Professor Akoko, who is the team lead, and with the team from the national level, from the district level, and from the local team that we have been incorporating them in doing these surgeries. And that's one of the picture showing the performance of the surgery. So we have been done on lymphedema management too, because with these challenges and this, it has been through mapping. We have of LF patients that we have said is 7 councils. We have doing training of frontline health workers who on morbidity management, and we have been doing health education to patients with lymphedema. For instance, once we have organized a meeting, we say, okay, you frontline health workers, you are in charge of the health facility. Please come to the meeting and come with 2 patients at least. And both, they just received training from the program. So we also do the lymphedema clinics. This is the process. It is under the process. So lymphedema management services currently are being provided at Kilwa, Kibaha, Mtama district, through the project which is under NIMBRI. It is called the Takeoff Project. Takeoff Project is implementing its activities into these two regions, Pwani and Lindi, where these districts are found. And we are aiming also to pilot a clinic that will be specifically helping these patients who have the challenge with the lymphedema. So probably after 1 year or 2 years, we'll be establishing a serious clinic that will be dealing with patients with lymphedema. So more than 1,000 patients have been reached. So through the process on morbidity management, the lesson learned is the health system know they are patients, but they don't know where they are. This is the gap. So we need to do mapping. So patients don't know where they can get care from the health system. So this is one of the initiatives that we want to establish. So for instance, once we succeed, it will be introduced into the health system. Not apart from the health system we have, but through this health system that we have. So few teams and staff have been trained. So the other lesson is reallocation of trained staff. Because what we have observed is we are training staffs at health facility A. After 6 months' time, this health staff is being shifted to another health facilities. So the people whom we directed them to get the services, they fail to get the services because of reallocation of the staff. After staff training, they remain unsupported. So we need to continue to support them. And availability of medical equipment at health facilities to provide care. That means we need a constant budget to make these services to be sustainable. So this is one of the picture of how we were training the frontline health workers. Frontline health workers mostly are the health facility in charges. So we taught them, and if you can look at the picture, the middle woman is the client. So we train them, and practically we show what we need them to do for the patients. So the requirements, you need to have the hygiene kit, which you need a bucket, a cup, a soap, small towels, and we train them. And if you look, we were showing them how hygiene practice is being conducted. And you can see them, they are looking eagerly to see what we were doing. And eventually, we ask them to do to the other clients. So that means what we have taught them, practically they have to do it. So the lesson learned from the patients. Patients, they don't know they can get care from the health system. So we need to assure them, to make assurance of what we are doing and to continue sensitize them. So patients feel if they cannot be cured, there is no need to attend the health facilities. Actually, we have observed this is the challenge, and so we have the big role to train even the health staff to know exactly what to do once they receive patients patients with acute filarial attacks. And most patients do not afford health services contribution cost. As we heard yesterday, it's very costly, so we need to make a mechanism of supporting them. So patients tend to hide themselves due to stigma from the society. I think from yesterday up to this moment, we heard about this stigma. They hide. Actually, they come and tell you, I cannot walk in the city because of the challenge. So psychological support is equally important as the care of affected parties. So we need to show concern to them and try to wear their shoes in order to save them. So not only the patients need support, but the family too needs support, psychological support, in order to segregate or to run away or to not supporting the client. We need to do it. And what we do is we have been training community health workers who are very close to these patients. So when supporting, engage them to the economic activities and being able to support themselves and their families. So once they are well, that means they can farm, they can do business, they can get confidence in whatever they want to do in their lifetime. So the way forward from the police perspective, we need to integrate the lymphedema management into the national health system through universal health coverage, incorporating lymphedema management package of care into national essential services package and the national standard treatment guideline. This is the way, one of the way forward. We need also to implement of existing NTD sustainability plan. The program has this sustainability plan, so we need to implement and finalize NTD financial strategy with strategies to increase domestic financing and financing at the primary health care. We have different stakeholders. Some of them, they don't know anything about these patients. So once we get opportunity to involve them, just invite them and tell them about, we have the challenge in our community, we can do something. And we have seen that with Statoil. Statoil is one of the companies that is doing oil mining in the Indian Ocean. What they get, the profit they have, they do offer services to the patients whom they are nearby to their area of their work. So we need to advocate for inclusion in upcoming mandatory universal health insurance benefit package, as we heard it yesterday. Maita Basa. Thank you, Shukran.
Thank you very much, Dr. Wilfred. Now I welcome the translator.
Noimba handivhuni rurimi rwamaizha ndichataura panapa. Saka zvataurwa naDr. Wilfred vati Tanzania, mainland Tanzania, tine island inonzi Ngozi, and then kune mainland. Kune zvirwere zvinowanzowanika kumahombekombe kwenyanza. Ndokwakawanda zvirwere zvacho zvakanyanya zve-lymphatic filariasis zvinokonzera hydrocele ne-lymphedema. And uwandu hwevanhu vanobatwa nechirwere ichi vanosvika about 31 million. Saka hurumende yeTanzania yakachienda district nedistrict vachiona kuti mune vanhu vangani vane chirwere ichi, and then zvimwe zvava kuita ndezvekuti vakabva vatsvaga uwandu hwevanhu vacho, vatsvaga uwandu hwevanhu vakaona kuti kune zviuru 10,000 vanhu vakakwanisa mapatients anofanira kubetserwa, kwouya vamwe vakatrainwa vanongoita chiuru chimwe chete. Saka pavakachitora manhano ekubetsera, vakatanga nekoko kumahombe kwenyanza kwamuri kuona kune kala yered uku, red inonzi mushona tsvuku, kune kala tsvuku uku ndokune matambudziko akawanda echirwere, but ndokozve kwavakaita mainterventions akati wandei ikoko. Saka vakaita madistrict akawanda, imwe inonzi Kibala, imwe inonzi Mutama, imwe inonzi Kitwa. Chimwe chavakazoona ndechekuti vakaona kuti varwere havazivi kuti vanonobetserwa kupi, uyezve ministry yehealth inoziva kuti kune varwere asi haizivi kuti varwere vari kupi, which means panofanira kuita program yemapping or yokuongorora kuti vanhu varipi and vanokwanisa kuzoya chirudzi kuzobetserwa. Nyaya yemari yakambobuda nezuro kuti unenge uchigara kure, and kuti uwane rubetsero unzibhadhara mari ndoimwe dambudziko ravakaona zvakare muno mutanzania nokuti varwere vanenge vasina mari. Imwe nyaya yakabuda zvezuro ndeyekuti unotarisirwa pasi nokuti une chirwere ichi. Saka varwere vazhinji vari kuti ini handikwanisi kubuda panze nokuti vanhu vanondishora. Saka nokudaro kurwara hakuchangove kurwara kuri physical but kwakubata futi kurwara yamunoti muchirungu mental health. Saka marwari vanofanira kuwana yavanoti psychological support kuitira kuti mental health yavo isanyanyoshat. And pakupedzisira vasitaura kuti kune mamwe makambani pachirungu munoti corporate social responsibility. Macompanies ari kubetsera vanhu vari munharaunda mavo kuti vawane rubetsero rwekurapa. Maybe ndochimwe chinhu chatokwanisa kufungawo zvakare kuZimbabwe kuti kana kune kambani dziri pedyo nepamunogara dzinokwanisa kubetsera nekuti vanhu vawane kurapwa. Chekupedzisira inyaya yakabuda zvakare zuro yokuti kana pasina yamunoti muchirungu medical insurance or insurance ine mishona hatina kuti insurance handiti kana pasina medical insurance or health insurance zvinonetsa chaizvo kuti ukwanise kuwana kubatsirwa. Saka pazvirwere izvi zvinenge LF nezvimwe medical insurance chimwe chinhu chokuti tinofanira kuongorora kuti chibetsere vanhu kuti vapote vachikwanisa kuona mishonga pavanoidira painenge yapera. Vazoratidza zvakare kuti savana chiremba vari muTanzania vari kuenda vachitoita maoperations munogara vanhu. So far vaita maoperations zviuru 12,000 maoperations avaita ekuti vanhu vaite zvakanaka. I think nechidimbu ndo tichamirira ipapo. Thank you.
Wilfred Mandara alikuwa anatoa kwa kifupi kuhusu Tanzania bara namna gani wameweza kuwa wakikabiliana na ugonjwa wa matende na mabusha. Ugonjwa wa matende na mabusha ulianza wilaya 119 ambazo zilikuwa zimeathirika na ugonjwa wa matende na mabusha. Lakini kufikia 2024 tumebakisha wilaya 7 ambazo bado zina maambukizi ya ugonjwa wa matende na mabusha. Ambapo watu ambao wako kwenye hatari ni milioni 31.36 ambao wako kwenye hatari ya kuweza kuambukizwa ugonjwa huu wa matende. Kuna njia mbalimbali ambazo zimekuwa zikitumika ili kuweza kutambua kupata wilaya ambazo zina maambukizi ya ugonjwa wa matende. Kuna wilaya ambazo zina magonjwa mengi, ugonjwa mkubwa kwa kiasi kikubwa ambazo ziko 54. Kuna ugonjwa ambao zina moderate wakati ambazo ziko wilaya 12, lakini pia kuna kidogo ambazo ziko wilaya 53. Njia zilizotumika kuweza kutambua hii ikiwa ni kufanya mapping, kuangalia, kupitia na kuangalia, lakini pia wakati wa tafiti ambazo zinakuwa zikiendelea za LF, lakini pia kuangalia pia wilaya za jirani kwenye tafiti, lakini pia na kuangalia kiwango cha maambukizi katika data zile zenye viwango vya maambukizi. Wamekuwa pia wakifanya operation za mabusha mpaka kufikia sasa wameshafanya operation 11,228 kwa kupitia njia za camp, ambapo kwa camp ilikuwa ni watu 10,000 na 10,020, lakini pia kwa wale watu ambao wamefundishwa katika vituo vya afya ni 1,208. Kiwango ambacho kinakadiriwa ni cha watu wenye mabusha na matende ni 21,206, ambayo nyingi zipo kwenye ukanda wa pwani. Kitu ambacho wameweza kujifunza ni kwamba kuweza kutambua wagonjwa wako wapi. Hiyo ni changamoto ambayo wamekuwa nayo, lakini pia wale wagonjwa hawajui wapi kuweza kupata huduma matibabu. Lakini pia kuna hakuna vifaa kwa ajili ya matibabu. Lakini pia kwa upande wa wagonjwa wenyewe hawajui kama watapata matibabu, lakini pia hawajui kama wana uwezo wa kuweza kupona, lakini pia hawawezi kugharamia gharama zile za matibabu kwa sababu tumeona ziko kubwa. Lakini pia kuna ubaguzi mkubwa wa hawa wagonjwa ambao tayari wameathirika. Kwa hiyo kinachoangaliwa hapo mbele ni kuweza kuhamasisha namna hawa ambao wameshaathirika kuweza na wao kuweza kuwa jumuishi katika kila kazi na kwenye kila kitu. Lakini pia kuna NTD sustainability plan ambayo ipo, kwa hiyo namna gani ambayo tunaweza tukaifanyia kazi. Asanteni.
And now I will allow room for discussion on the previous presentations. Dr. Mandaras, and if you had any other comment on the previous presentation, you can also comment while we're waiting for lunch break. Welcome. Nakaribisha maswali, maoni kwa ajili ya presentation ambazo zimefanyika.
Thank you very much for a very good presentation. But my comments goes to whoever was commenting or answering the professor's question. Yeah, I was concerning, like, I don't know, I can give you the experience from wherever the health facilities in our country, like from dispensary level, health center, district level, regional, up to the highest level for the health facilities. So when you were trying to comment on the capacity building, I don't know, the diagnostic part of it, and the healthcare workers to diagnose the proper, to misdiagnose and doing the proper diagnosis. So I was like thinking on, like, you get a patient who is vomiting blood, and sometimes you miss what caused the vomiting of the blood. So I do think, like, the proper history taking will lead you to the proper diagnosis, and probably you have that diagnosis of maybe somebody can, as I said before, she can have vomiting blood due to peptic ulcer disease. But if you really took the proper history pertaining, like, somebody cannot vomit blood today if she had no previous history of the peptic ulcers, or you just get to know where is she coming. And sometimes not all of them who vomiting blood, they come with a huge the abdominal swelling. That's the advanced stage of the disease. So maybe you have that diagnosis, I don't know to what level. In our practice, we normally, if you see that patient in the lower level, you have to transfer that patient to the proper facility where they can intervene. Like, if you cannot do the endoscopy, you cannot do the ligation, and that is sometimes an emergency. So these patients, I think, they are sent to the facility where they can be proper managed, or the proper investigations can be done there. Probably you are in the facility where you cannot manage to do the ultrasound, or if you do the ultrasound, the one who managing the patient has not much knowledge to have that diagnosis. Like in our low level facilities, probably you meet somebody with advanced diploma, you meet clinical officer, or you meet a doctor with a first degree. Probably sometimes it might be difficulties. So we do multidisciplinary managing of these patients in our experience. Like, if I see that patient, I'm a gynecologist, I think if I'm suspicious of maybe she's having periportal fibrosis or she's having peptic ulcer disease, I think the physicians or the gastro physicians might be better managing this patient other than me. So we do the multidisciplinary team working rather than just concentrating with this patient, probably I might be a proper person to manage this patient. That was my comment.
Thank you, Dr. Mina.
Thank you, my brother, for a very fascinating presentation. So I have three issues. I think two reflection of a project that we have just completed. I was talking to Paul and to Humphrey that we just completed a research project on cancer care in Tanzania, in Kenya, and in India. And what is striking is all these things that patients are talking about in terms of access, and access being a maze, not knowing where to go. That's what we found in the cancer care case, that patients do not know at what point of entry would be best for them to get access, and when they get into the system, they don't know where to go. So it's a maze. So my suggestion is it possible to find a way of actually mapping out the treatment pathways, where you tell a patient, if you present with something like this, you go to this type of facility. If this is not okay, then you go to this facility, or you see this specialist. That's by way of suggestion, one of the things that could help. The second one is on the financial challenges. Now, correct me if I'm wrong. I thought Tanzania has this, is it NHIF, the National Health Insurance Fund? Does it cover? So if it is there and it's insurance at national level, should there not be advocacy to push for this to cover for the patients who will go 1 month to get medication, and then they'll go, and when they start vomiting again, they come back because they can't afford. So maybe there is something that we can learn from HIV programs and then transfer it to this. Then the third one is, I think, the science communication and advocacy. What has come through is the patients do not have a voice. Is there space where you have advocacy groups, or you have people like Cancer Society or people who in a way help the people understand the information, they become a point of call for information, and secondly, they also help give them a voice and deal with these issues of feeling looked down upon in society. So there were not questions, no suggestions from what we have learned in our project. Then the final thing is, I think you raised something that was very important. You said you don't only deal with the patient, you deal with the family. We also found something similar in our research on cancer care, and our colleagues in Kenya called it the social pain of cancer. That it doesn't only affect you, it affects the people that are around you, because you have to go and borrow money, and after some time, these people simply say, you're not becoming a burden, we don't want to see you. And so marriages break down, relationships break down. So there's a social pain that comes from a disease, and some of these advocacy groups and insurance can actually help in alleviating some of these social impacts of disease. Thanks.
Thank you very much. Anyone with comments, additions?
I just want to comment on the issue of diagnosing cystosomiasis on upper gastric bleeding. I said this platform gives me a learning phase that cystosomiasis can present with those signs and symptoms. So I'm thanking the team, so that I am here, and with the Zimbabwean team, we have learned something from this platform. Thank you.
Thank you very much, Sister Kwenda. Any other comments or addition? We still have 5 minutes before we break for lunch.
Mine is a question. I just want to ask if bilharzia can complicate to cancer if the eggs are found around the cervix.
Thank you very much for a very nice question, but I think this should be will be answered at the coming sessions after the lunch.
Session. So there will be a presentation on schistosoma hematobium on the last session after lunch.
Oh, I've realized that Tanzania and Zimbabwe have got something in common, whereby the Minister of Health knows that there are patients out there, but they do not know exactly where they are. For Zimbabwe, we intend to increase surveillance, which is community-based, so that the frontline workers, the village health workers, will be able to come up with a late definition, so that those cases can be picked up very early. And then for the health facilities, we have an indicator-based survey, so that we can closely monitor what's going on in the field. Thank you.
Hello. Thank you. My brother from Zimbabwe has also preempted me a bit. But what I wanted to say, we share problems. These problems are very common. And I'm wondering, as Taka said earlier on, through the programs, we are working very hard to get the diseases controlled or eliminated. We see what Mandara presented. We started with 119 IUs or districts. Today, we're doing MGA in only seven districts. From an implementation research point of view, if I'm to ask the program, do you have anything? Do you have any information on the 100 and the 112 which have stopped MGA? Do you have reliable information on the current status of transmission? What's happening in the community? I tell you, that might be a very difficult question to answer. Just food for thought as we go for lunch and let alone depart, go back to our countries and homes. One of the most challenging part of controlling these diseases, when you eliminate and you don't want to see the diseases coming back, recrudescence. Unfortunately, most of the African countries, that part has proved to be very difficult, despite the fact that we have a health system which is well streamlined up to the community health system. Surveillance is not easy. It can be made easy if innovation is added to it. But seeing the way we are struggling to just control these diseases, to do mapping of morbidities and disability. No in the country here, among us who are participating, we know the really burden of disabilities derived from entities. We don't have the data, neither the ministry nor at least us, research institution, who has NIMRI in Tanzania, we are able to stand tall and say, we have this set of data we can. But you go to the ministry, apart from LF, and that data is because NIMRI was doing this. The ministries, I can tell you, they'll struggle to give you the data. Now, if they don't know the burden of disability, how will they be able to do surveillance and control and stop recrudescence of the infection? This is food for thought. Something we need to think together, is something we need to speak loudly, not fearing for anything. When you eliminate a disease, the hardest part of stopping it from coming back begins. Thank you.
Hello. I'm going to say something out about this ISMA. I've realized that in Zimbabwe we are saying we don't have this ISMA Sanai. But when I was looking here, I heard that it is from Africa we can get it. So Zimbabwe cannot be spared. Because as I was thinking and hearing the presentations, I discovered that as in medical staff or nurses, we miss these diagnoses because we don't check the full history of our clients. Some of the diseases, like the people who present with chills, fever, headache, we expect they have malaria. But when diagnosed, when we have the necessary equipment like test urine and stool at the facilities, we can pick up this condition. Thank you.
Thank you very much. One more comment. Okay, and thank you very much, Dr. Wilfred Mandara, for the presentation, and thank you all for participating in this great discussion. May you all clap for ourselves. Yeah, we did a good job. So now we are going to break for lunch, then we'll continue the last session and wind up the meeting.
What time are we resuming?
Good afternoon, everybody, and welcome back. Thanks for your patience. We had a little bit of technical difficulty. So while I have your attention, welcome back to the very last session of our meeting. We have a very exciting agenda ahead. And this session will mainly be centered on launching of a very, very beautiful comic book. You all see it, it's amazing. I'll jump straight to it, we don't have time. First up, we have Dr. Banda, who will provide an introduction to the comic book for us. Dr. Banda, floor is yours.
Habari. Maskati. Mulibwanji. Thanks. So I have been asked to give a brief background about the comic book. This is one of those projects that has been so long in the works that sometimes you forget about it. I was talking to Masood yesterday. He was saying, "Oh, I have really forgotten about this." So there was a time when TIBA was going on, TIBA 1, and we were looking at how do you give information that is manageable and that is size, what called bite-sized chunks, that's easy for children to understand and to digest. And we had looked at the cartoons that were there on the internet and elsewhere, but we found something that we felt uncomfortable with. Whenever our children watch TV or movies, they are seeing heroes, but the heroes are foreign, and the heroes don't look like them. So we then said, why don't we look at a cartoon booklet that has an African hero that our children can relate with? And so the message can be better digested by the children. So we then sat down with a colleague called Vera Kenda, and we did a brief, and Vera said, you know what, I know someone in Tanzania who is one of the best cartoonists in East Africa. Why don't we talk to him? So we got in touch with Masood and said, Masood, this is what we want. And so we gave him a brief, and he came with the first version, and then we circulated to our Tanzanian colleagues, circulated to the Zimbabwean colleagues. We changed some things, we sent it back to Gareth, and so not to Gareth, sent it back to Masood, and Masood worked on it, and then COVID happened. So all these things that I'm talking about, I think were around about 2018, 2019. So when COVID happened, the whole world, for some of us, went upside down. And so we buried it. And then my sister Francisca says, where is that comic book? And then it was taken out. And I'm grateful for Gareth, Lorraine, Tagwire, Mduluza, and the others in Zimbabwe who have worked. And where is my brother Humphrey? And Humphrey and Cecilia, who worked on this booklet that was in English, to translate it into Shona and translate it into Kiswahili. So that, I think, is a brief background of the way that we approach this thing, and also just trying to change the narrative, that you can actually create narratives of hope using people that you know that you can relate with. I don't think I finished my 5 minutes, so I shall give over to my brother Masood, right? You see, I keep time. Clap for me.
Thank you, Dr. Banda. So next up, we have Masood to officially launch the comic book first.
Now, the way you put it, to officially launch. Yes, hi, my name is Ali Masood, but I am mostly known as Masood Kipanya. I'm a political cartoonist, and I have been drawing cartoons for over 30 years now, professionally. I started in 1989. They say I'm the leading cartoonist in Tanzania. I don't know about that, but I also work for a radio station as a radio presenter, producer, doing the morning show, the leading morning show in Tanzania, you know, in the leading radio station in Tanzania as well. I was approached by my friends, Dr. Banda and his team. They wanted me to come up with an African hero because they say they were sick and tired of, they were looking for sort of Wakanda, you know, an African, not hero, a female hero. So I tried to do some sketches, and we came up with the name Lady Tata, not Lady Gaga. Yes, Lady Tata. And as Dr. said, it is 5 years now. I've almost forgotten about the illustrations in the book, but here we are today. I am tasked to say that we are going to launch it, and the book is here. I saw it yesterday, actually. And now this is the Swahili, there's the Swahili version, and English, and Shona. Okay, I believe that we may be able in the future to translate it into more African languages, you know, for the benefit of our people, especially kids, because as you all know that the reading culture in Africa is declining day by day. So if you put artworks in a book or an article, at least people get to read it, especially kids. So that's briefly it. You haven't seen it yet, huh? You only see the drawings here. How do I launch? I'm not a politician. Eh? I'm doing well. So, ladies and gentlemen, here is the, okay, 3 versions, huh? Swahili, English, and Shona. Where is Shona? This is Swahili. Anyway, they can be represented. So here's the book. It has about how many pages? About 30 pages. A very simple. Yes. So here it is. Thank you very much. Yeah, and just to add a bit, today I was also trying to follow the discussion, and I did some drawings of which I think Dr. Banda will come and show you later. But what transpired from the discussion, I'm not a doctor, I'm an artist. I saw poverty. I only saw poverty. We are facing what we are facing today because of poverty. When I was listening to the case of Ukerewe, that you know, people were not able to go to hospitals just because of that they couldn't afford. It is similar to Zimbabwe, you know, and other parts of the world. Okay, you want me to talk about this? Okay, so I did this cartoon today when I was sitting there. Donor dependence. Sorry to say that, but that is what I saw, because I still believe that Africans, the governments can fend for themselves, as in, dealing with these diseases. But we are highly depending on donors. I only did 3 illustrations. The second one is yeah, that one. Yes, the government official trying to give a bottle of water to the neglected, person who wants more than that what is in the bottle. And the third one and the last one is it's a compilation of so many things. I was following the meeting, and this is what I saw. So it's like here you have a person vomiting blood. They want to go to the hospital, but you look at the crocodile there, which is poverty to me. When the presenter from Zimbabwe, when he was speaking, he spoke about the water coverage, but I also saw the issue of myth. We are being told that you've been bewitched. We normally get that. You get kids who are swimming in the same pond. The animals are using the same water, and our mama is also fetching the same water for us to drink. The problem, we are like in a vicious cycle. It will never end. Why? Because of the lack of clean and safe water. And when you think about water, it really pisses me off because we are sitting on top of a huge deposit of water in Africa. But now look at the way we scramble for this important resource. So poverty, and somebody spoke about behavioral change, which I think, yes, sometimes we don't need money. We only need to change our attitudes towards these issues. And the snail is asking you, you want to beat me? Eradicate poverty. But also the issue of community leaders to just create the awareness to them, etc., etc. So thank you very much.
Thank you very much, Masood. That's amazing. I think all these comics have captured the essence of our meeting very, very well. And let's appreciate him again, please. Next, story time. Someone say story time. Oh, are you hungry? You just ate. Story time. Thank you. We want to have a very brief walk through the comic book, so we all know what the comic book is about, what the story entails. And so we will have 2 concurrent readings, one in Shona and one in Swahili at the same time, so we can all follow the story. We don't want anyone falling asleep. And so I would invite Drs. Tagwe and Dr. Olubayo to join me upstage to help me with the reading. Who's doing a Swahili translation for me? Oh, are we distributing the books now? No? Okay. Okay. Can someone do a Swahili translation for me, just to introduce? Anybody? All right. Hey, is everyone ready?
Labda nitoe tu kwa ufupi kazi ilikuwa inafanyika hapa mbele. Ilikuwa ni uzinduzi wa kitabu kwa ajili ya ugonjwa wa kichocho kwa ajili ya watoto mashuleni. Ilionekana kuna upungufu au kuna upungufu kwamba wale watoto ambao wako shuleni elimu ya kichocho haiwafikii ipasavyo, na ikaonekana kwamba kwa sababu watoto wengi wanapendelea kuangalia katuni, basi wakitengenezewa kitabu kama hiki kitaweza kuwasaidia, watakuwa wanajisomea na kitaweza kuwasaidia kuelewa madhara na wa ugonjwa wa kichocho. Kwa hiyo kilichokuwa kinafanyika hapa mbele na kaka Masudi alikuwa anazindua hichi kitabu kwa ajili ya sasa kuweza kutumika kule mashuleni na kwa Tanzania, kwa Zimbabwe na hatimaye kwa bara lote la Afrika ili kiweze kuwasaidia. Kwa hiyo ndio kimezinduliwa rasmi na ndio maana kila mtu amepewa kopi yake.
Right. Saka in short, nyaebu kama kabata. Alo njiwa na katuni. Ano kama katuni mkuma namba. Nyika yesha kwa Tanzania mno. Saka ya kata makatuni arumu. Sasa kutapana pataku werenga buku iri tete. Ikati ndikaverenga nechishona. Awaverenga ndikaverenga nechishona. Sisa awaverenga nechishwahili. Takabata ya mabuku yenye chifambe takada. We can start. Right. Musoro wenyaya. Lady Dachka. Lady Dachka. Lady Tata. Lady Tata kuma ombe kombe eda mureka riba.
Mwanamke tata na mashua yake ya uokoaji.
Kache isare musha wakanaka urikuma ombe kombe eda mureka riba. Vazhinji vevagari vemo vabati vehove uye vashoma nene kwazo vanorarama nekurima.
Lava ni jina la kijiji kizuri sana ambacho kipo kando kando ya ziwa Limpapa. Wakazi wengi wa kijiji hiki ni wavuvi na wachache wanategemea kilimo.
Kana vasiri kuchikoro vana vanonakidzwa nokutiva murwizi ruri pedyo nemusha.
Wakati hawako shuleni, watoto hufurahia kuogelea kwenye mto ambao uko mwishoni mwa kijiji.
Musi masikati emugovera varedzi nemadzimai vari kudzoka kubva kunoraura, vamwe vari kudzoka kubva kumapindu, uyewo vana vari mushishi kutamba nhabvu neimwe mitambo.
Ni Jumamosi mchana, wavuvi na wanawake wanarudi kutoka katika shughuli za uvuvi. Wengine wanarudi kutoka mashambani na watoto wanacheza mpira wa miguu na michezo mingine.
Takafu ane makore 12 ekuberekwa haasi kutamba bhora nevamwe kunze. Pane chakonzera kuti adaro anga asingafare sevamwe kwenguva inenge vhiki.
Dennis ambaye ana umri wa miaka 12 ni miongoni mwa watoto wanaocheza mpira nje. Kuna kitu hakiko sawa kwake na kuna kitu kinamtatiza na amekuwa na hali hii kwa takriban wiki nzima sasa.
Chakafu mumwe wenyanzvi dzevatambi venhabvu mumusha umu vanotomuti Messi.
Dennis ni mmoja wa wachezaji bora wa mpira wa miguu hapa kijijini na wanamuita Messi. Kijana wangu.
Baba vachakafu vanofunga kuti mwana wavo akaroiwa. Achangobva kufirwa namai vake, vanofunga kuti mhuri yavo iri kunangwa nevaroi.
Baba yake Dennis anafikiri kijana wake amelogwa. Siku za hivi karibuni, Dennis alifiwa na mama yake. Baba yake anafikiri familia yake inalengwa na wachawi.
Waitwa sei mwanangu? Uipirwe musha uno. Hauzorori kusvika vatipedza tose.
Wamemfanya nini mwanangu? Wabaya wa kijiji hiki hawawezi kupumzika mpaka watumalize wote.
Baba vachakafu vanosarudza kuenda nemwanakomana wavo kwa madzibaba vanogara musha mumwe chete navo.
Baba yake Dennis akaamua kumpeleka kijana wake kwa mganga wa jadi anayeishi ndani ya kijiji chao.
Ririsei dumbu rako, uchiri kunzwa kurwadziwa here?
Vipi tumbo lako? Bado unahisi maumivu?
Hongu baba, uye mangwanani ano pandinoenda kuchimbuzi ndaona ropa, mutsvina nemuweti yangu.
Ndiyo baba, na leo asubuhi nilipoenda chooni kujisaidia, niliona damu katika kinyesi changu.
Aishe wangu, ropa, mutsina, nemuweti, chii chiri kuitika?
Mungu wangu, damu kwenye kinyesi. Ni nini hiki kinaendelea?
Mira hako mwanangu, kutambura kwako kwava kutopera. Tichaudzwa kuti ndiani ari kukonzeresa izvi.
Usijali, vumilia mwanangu. Muda si mrefu maumivu yako yataisha. Muda si mrefu tutafahamu nani yuko nyuma ya matatizo haya.
Chakafu, munhu mukuru achiri kutaurwa na baba vako.
Dennis, wewe ni mtu mzima sana. Kubebwa na baba yako?
Mukoma Petsai, chikafu ari kurwadziwa nemudumbu uye ari kuita tsvina neweti ine ropa.
Kaka Obi, Dennis ni mgonjwa, ana maumivu ya tumbo na kinyesi chake kina damu.
Ndiri kumuendesa kwa sekuru Maganzo.
Ninampeleka kwa chifu Maganzo.
Ndine urombo mukoma, uyezve mwanakomana wangu anga achinyitawo nezvekurwadziwa nemudumbu make.
Samahani sana kaka. Hata hivyo, mwanangu pia amekuwa akilalamika kuhusu maumivu ya tumbo.
Hanzvadzi, pane zviri kuitika zvakashata zviri kuitika mumusha medu. Ndikuudze.
Ndugu yangu, kuna kitu hakiko sawa katika kijiji chetu na kuambia.
Vagari vazhinji vemusha uyu vakange vakubuda pachena nevana vavo.
Wanakijiji wengi zaidi walianza kujitokeza wakiwa na watoto wao.
Vakomana, chii chiri kuitika? Amai namwenesu, uyai. Nai namo, chii chiri kuitika?
Jamani, ni nini kinaendelea? Mama Vusi ana tatizo gani?
Namo ari kurwara, anorutsa zvakanyanya paanoita tsvina uye rinobuda rine ropa. Ndiri kuendesa mwana wangu kwa sekuru Maganzo.
Vusi ni mgonjwa, anatapika sana. Anapokuwa anajisaidia haja kubwa, damu inatoka. Ninampeleka kijana wangu kwa chifu Maganzo.
Mazvionaka mukoma Petsai, tose tine dambudziko rimwe chete.
Je, unaamini sasa kaka Obi, tatizo lile?
Dambudziko rimwe chete? Zvinhu zvakatokomba nhai. Ndiani ari kutiitira izvi?
Kwa sasa hali ni mbaya sana. Hivi ni nani anatufanyia hivi?
Vagari vakawanda vemumusha uyu vakange varwadziwa pamusoro pedambudziko ravakange vakatarisana vachinyunyuta pamusoro pezvakange zveitika kune vana vavo.
Ghafla, wanakijiji wengi zaidi walijitokeza na kulalamika kuwa watoto wao pia wanasumbuliwa na tatizo hilo.
Ndatozorega kufamba nhasi nekuda kweurwere hwemwana wangu.
Watoto wangu wawili bado nilitakiwa kusafiri leo, lakini imenibidi niahirishe kutokana na ugonjwa wa mwanangu.
Vana wangu vaviri vari kurwara, vakarara kumba, vari kurwadziwa chaizvo.
Watoto wangu wawili bado wako kitandani, wanaumwa sana.
Mwanasikana wangu hana kudzikotsera hope nezuro manheru.
Binti yangu hakuweza kulala kabisa usiku wa jana.
Sando rakapera ndakatorota zvinotyisa. Musha wedu uno uchiputirwa nerimi remoto asikana.
Wiki iliyopita niliota ndoto mbaya sana kwamba kijiji chetu kilizungukwa na moto.
Hede, saka icho chaive chiratidzo chazvose zviri kuzoitika.
Kumbe ilikuwa ni ishara ya haya yote.
Chokwadi, iri dave kufunga zvekutama musha uno une zviitiko zvakadai zvakashata.
Kwa kweli sasa ninafikiria kuhama kijiji hiki kinachoandamwa.
Zvinobatsirei kutiza musha wako nenyaya yenhamo? Takazvarirwa muno, tinoenda kupi? Madzitateguru edu angatogumbuka kana tikasiya musha yedu.
Kuhama hakutatusaidia kitu. Tulizaliwa hapa, kwa nini tukimbie? Mababu zetu watatulaani ikiwa tutahama na kuacha kijiji chetu.
Zvino iwo mazitateguru ngavachitipaka mazano negwara rekuita.
Basi kama ni hivyo, mababu zetu wanapaswa kutupa ishara yoyote.
Vakomanaka, mubvunzo ndouyu, ndiani ari kutiitira zvakadai?
Jamani, swali hapa ni nani anatufanyia hivi?
Ndofunga kasekuru kaya kanogara kega mumusha medu umuka. Handimufariri muntaraunda zvachose.
Nadhani ni yule mzee anaishi peke yake pale mwisho mwa kijiji chetu. Simwamini hata kidogo.
Zviri nani kuti uvimbe naye, ini handitomudi zvachose muntaraunda.
Angalau wewe humwamini, mimi simpendi hata kidogo.
Ko mai hazviperi, vanoratidzika kunge vasinganzwisisiki mai vaya. Havambotarisana nemunhu kumeso, vanogara vachinyara-nyara.
Vipi kuhusu mama Gugu? Anaonekana wa ajabu sana. Hawezi kukuangalia machoni kamwe. Anaona aibu wakati wowote.
Vanofanira kuve vachivanza chimwe chinhu chakaipa mai vaya.
Ndio lazima itakuwa naficha kitu kibaya.
Ndine urombo evarume, asi handivimbe namai vangu. Vanogara vachitaura vega, pandinovateerera vanobva vanyarara.
Jamani, samahani, lakini mimi simwamini mama yangu. Mara nyingi huwa anazungumza peke yake, nikimtazama kwa macho nikitazama kwa mkazo anaacha.
Ipapo pakabva paita ruzha rukuru uye nechiedza chakabva kudenga. Mhomho yevanhu yakanyarara kwekanguva, pakabva paonekwa chisikwa chisinganzwisisike kubva kudenga.
Ghafla kukawa na sauti kubwa na mwanga mkali kutoka angani. Umati ulinyamaza kwa sekunde moja. Kisha kiumbe wa ajabu akatokea angani.
Hachina kuoneka zvakanaka nekuda kwechiedza chakanga chakafukatirwa nezvinhu iri. Chisikwa ichi chaive nechimiro chemunhu.
Hawakuweza kukiona vizuri kutokana na mwanga mkali uliokuwa nyuma yake. Kiumbe huyo alikuwa na umbile la binadamu.
Naishe wangu, chii hicho chinenge ngozi?
Bwana wangu, ni nini hicho?
Ingerozi?
Malaika?
Satan?
Ibilisi?
Hasungamire zvakanaka.
Hakiwezi kuwa kitu nzuri.
Tiza, manya neupenyu hwako, hameno zvako.
Kimbia ili kuokoa maisha yako.
Raive gamba rechikadzi.
Alikuwa ni shujaa wa kike.
Makadive dare, zita rangu ndinonzi Lady Tata. Sei muchifungira akakonzeresa dambudziko renyu? Mune humbo here pamazita amunotaura?
Hamjambo, niiteni mwanamke Tata. Kwa nini mnakisia ni nani ambaye ndiye chanzo cha matatizo yenu? Je, mna ushahidi wowote juu ya majina mnayoyataja?
Ko nai imi, iye mukadzi murombo kana kuti harawa yazvikurira zvayo, vangadarirei kuuraya vana venyu? Vanodya vanhu here?
Kwa nini mnadhani yule bibi maskini au yule mzee mpweke anataka kuwaua watoto wenu? Je, kwani wao wanakula watu?
Ndinozviziva kuti mumusha muno hamuna nzvimbo dzeutano dzakakwana, asi kana zvasvika pautano hwenyu munofanira kutsvaga rubatsiro kubva kune vane unyanzvi hwekurapa, kwete kutsvaga anofungirwa kuti muroi akaita izvozvo?
Ninaelewa kuwa hakuna vituo bora vya afya hapa, lakini linapokuja swala la afya yako, lazima utafute usaidizi wa matibabu kutoka kwa wataalamu wa afya. Je, kuna yeyote kati yenu amefanya hivyo?
Asi kwatingawana rubatsiro rweutano kure nekuno madhamu, kure chaizvo.
Lakini zahanati iko mbali sana na hapa mama, mbali sana.
Kangani kamunofamba makilomita akawanda nemichovha kudaro muchienda kumitambo yemichato. Nguva zhinji sei musingakwanise kuenda kure zvakadaro nekuda kweutano hwenyu?
Je, ni mara ngapi umesafiri umbali wa mrefu kwa mtumbwi ili tu uweze kuhudhuria sherehe za harusi? Mara nyingi sana. Je, ni kwa nini huwezi kwenda mbali kwa ajili ya afya yako mwenyewe?
Hey, saka anoziva zvinhu zvedu zvese. Mudzimai huyu ndiani?
Kwa hivyo anafahamu karibu kila kitu kuhusu sisi. Je, huyu mwanamke ni nani?
Handizive, anofanira kuve ari ngirozi. Anoona zvatisingaoni.
Sijui. Lazima tu atakuwa malaika. Anaona kile ambacho sisi hatukioni.
Hurukuro yakazowedzera kugadzikana kwehana dzavo. Chakafu akabvunza mubvunzo.
Mazungumzo yalipozidi kuwa ya amani baina yao, Dennis aliuliza swali.
Naiye ditata, unoti tikaenda kuchipatara teshe tinopora todzokera kuupenyu hwedu hwekutamba bhoya yeye?
Mwanamke tata, unasema ama unamaanisha kwamba tukienda hospitali sote tutapona na kurejea katika maisha yetu ya kawaida ya kucheza mpira?
Hongu chakafu, muchatariswa mese kuti dambudziko renyu nderei uye kuti muwane mishonga.
Ndiyo Dennis, nyote mtafanyiwa vipimo ili kujua shida mlionayo na mtapata dawa.
Anajua shida yangu.
Ndiyo, unajua jina langu?
Iwe unongofanirwa kutevedzera mirayiro yaunopiwa navana chiremba.
Mnatakiwa tu kufuata maagizo mtakayopewa na madaktari.
Iwe kana uchinge wapora uchafanirwa kuve nechokwadi chekuti haudzokeri kuchirwere chimwe chete nekuzvichengetedza zvakanaka iwe neshamwari dzako dzose. Zvinokosha zvikuru kuzvidzivirira. Hatisati taziva, asi chero zvamuri kutambudzika nazvo vakomana zvinogona kukonzeresa rufu.
Na ukishapona itakubidi uhakikishe kuwa utajikinga usipate ugonjwa ule ule kwa kujitunza vizuri wewe pamoja na marafiki zako wote. Ni muhimu sana kujilinda au kujikinga. Bado hatufahamu chochote kama maradhi yanayowasumbua yanaweza kusababisha kifo.
Seza tambotaura madamu, chipatara chiri maawa mana kubva pano nechikepe.
Kama tulivyosema mama hapo awali, kituo cha afya kipo umbali wa masaa 4 kutoka hapa kwa kutumia mashua.
Toita sei manje? Tagara tichitarisira kubatsirwa kuchivanhu.
Tutafanya nini sasa? Tumaini letu pekee lilikuwa kupitia matibabu ya asili au ya jadi.
Ini ndinonzwisisa dambudziko renyu uye ini ndichakubatsirai, asi imi munofanirwa kubvunza vatungamiri venyu kuti sei musingakwanise kuvaka zvipatara munzvimbo dzenyu. Ibasa ravo.
Ninaelewa changamoto yenu na nitawasaidia, lakini lazima muwahoji viongozi wenu. Kwa nini hawajengi vituo vya afya katika maeneo yenu? Ni wajibu wao.
Kana pawanikwa murwere anoda kuendeswa kuchipatara zvekumhanya, murwere wenyu anokwanisa kusasvika kuchipatara achiri neutano nekufamba nechikepe kwemaawa akawanda kudaro.
ukipata changamoto ya dharura, huenda mgonjwa wako asiweze kufika kituo cha afya kwa kusafiri kwa mashua kwa masaa mengi. Nifuateni mimi.
Nditoverei. Leti tata akatanga kufamba akananga kumahombe kwedhamu, vanhu vakamutevera vakangwarira. Panguva iyi musha wese wakanga wanzwa nezvaledi tata.
Mwanamke tata alianza kuelekea katika ufukwe wa ziwa na umati ulimfuata, lakini kwa tahadhari. Mpaka hapo kijiji kizima kilikuwa kimeshasikia kuhusu mwanamke tata.
Hey, honai, alikupuruka. Hatsiki basi.
Hey, angalia. Anapaa, haguzi ardhi.
Izo zvisikwa zvinoera. Hazvingobata pawasika tsoka dzako dzakaipa.
Hao ni viumbe watakatifu, hawagusi mahali popote unapokanyaga na miguu yako mibaya.
Bata mdomo wako wakashata iwe.
Angalia mdomo wako mbaya.
Pakaita kunge panga paine musangano mukuru, vanhu vakawanda vakaramba vachitevera Lady Tata, vachishaya kuti ndiani mukadzi uyu akanga achifamba nemhepo.
Ilikuwa kama mkutano mkubwa. Watu wengi zaidi waliendelea kumfuata mwanamke tata wakishangaa. Huyu mwanamke anayeelea angani ni nani?
Chiri kuitika naimi?
Nini kinaendelea?
Zvishamiso.
Miujiza.
Vachisvika padhamu, Lady Tata akasimudza maoko ndokutaura mashoko asinganzwisikanwi. Igwa jena rakanaka rakatanga kuoneka.
Walipofika ziwani, mwanamke tata aliinua mikono yake na kusema maneno yasiyojulikana. Mashua nzuri nyeupe ikatokea.
Vanhu vakanzi vakwire. Zvaishamisa kuti vanhu vose vakapinda uye igwa harina kumbozara. Kwirai mese.
Watu waliambiwa wapande. Cha kushangaza, watu wote waliingia na mashua haikujaa. Ingieni ndani.
Mwari wangu. Ichi chingave chii?
Mungu wangu. Hiki ni nini?
Chikepe. Iwe zvako zvingori zvitanda zvakarongwa.
Ni mashua, hizo zenu ni mbao tu.
Ndisati ndamboona igwa rakanaka kudaro muupenyu hwangu.
Aisee, sijawahi kuona mashua nzuri kama hii maishani mwangu.
Muchikepe vanhu vakapiwa zvinwiwa netwudyiro. Vakabatwa neruremekedzo rukuru.
Katika mashua watu walipewa vinywaji na vitafunio. Ilikuwa huduma nzuri kiwango cha daraja la kwanza.
Ini zvangu ndafarira kuti ndiri mupenyu. Nenyaya yekuudza vazukuru vangu mashura ndakaona.
Nina furaha kuwa hai. Nina hadithi ya kuwaambia wajukuu wangu kuhusu miujiza ambayo nimeiona.
Chimbofungidzira kuti pahombekombe panga pasina igwa. Angotaura manzwi mashoma. Ndiye nyuku. Igwa rasvika.
Hebu fikiria. Hakukuwa na mashua ufukweni. Alinong'ona tu maneno machache, mara mashua ikatokea.
Nguva shoma igwa rakasvika mumusha umo maiwanzopedza maawa mana kuti risvike. Vakamhanya kuchipatara uko vana vose vakabva vapinda kunoongororwa nachiremba.
Baada ya dakika chache, mashua ilifika katika kijiji ambacho wangetumia masaa 4 kufika. Walikimbilia kituo cha afya ambapo watoto wote walihudumiwa na madaktari.
Kudzivirira bongozozo, Lady Tata akasarudza kusaenda kuchipatara, akavamirira zvake ari muchikepe.
Ili kuepusha mtafaruku, mwanamke tata aliamua kutokwenda kwenye kituo cha afya. Akawasubiri kwenye mashua.
Pachipatara vana vose vakatorwa weti netsvina naProfesa Mudhulusa kuti vaonekwe utachiona.
Pale kwenye kituo cha afya, sampuli ya mkojo na kinyesi zilichukuliwa kutoka kwa watoto ili kuchunguza vimelea vya magonjwa.
Ndirikucha ansipati ndamboenda pachipatara.
Ninaogopa. Sijawahi kwenda kituo cha afya hata siku moja.
Anditi ndakamboenda kudispensary pandakanga pavaigara natete kudhorobha.
Siogopi. Nimewahi kwenda zahanati kipindi cha nyuma nilipokuwa nikiishi na shangazi yangu mjini.
Inini yangu inandifariri kujungwa jekini.
Sipendi sindano.
Vana venyu vakabata parazia, chirwere chinokonzerwa nemakonye anoparadzirwa nemvura ine utachiona.
Watoto wenu walipata maambukizi ya kichocho. Ni ugonjwa unaosababishwa na minyoo ambayo huenezwa kupitia maji machafu.
Zamauya nawo pano kuchipatara isarudzo yakanakisisa. Chirwere ichi chinorapika asi chakasarapwa chinogona kukonzeresa urwere wakaipisisa.
Kuwaleta kituo cha afya ilikuwa ni uamuzi bora zaidi. Ugonjwa huu unaweza kutibika, lakini ukiachwa bila kutibika unaweza kusababisha madhara makubwa.
Ano mapiriti ndapota onai kuti mwana anonwa ese sekurairwa kwaitwa marairo ekunwiwa kwawo akanyorwa papaketi rega rega.
Hipi hapa vidonge. Tafadhali hakikisha kwamba wote wamemeza kama ilivyoelekezwa. Tumeandika maelekezo kwenye kila kifungashio cha dawa.
Vana vose vakaongororwa uye vakarapwa zvakakodzera vakadzokera kuchikepe. Chakanga chiri chiitiko chikuru, vana vakaudzwa kuti bilharzia inonziwo schistosomiasis.
Watoto wote walipata matibabu sahihi na kurudi kwenye mashua. Ulikuwa ni uzoefu mzuri sana. Watoto waliambiwa kwamba ugonjwa wa bilharzia pia unaitwa kichocho.
Lady Tata, munoti maizire here zvataitambura nazvo?
Mwanamke tata, ulisema ulikuwa unafahamu kabla ugonjwa uliokuwa unatusumbua.
Hongu chenai moyo, uye ndichakuudza nezvekudzivirira kana tasvika kumba. Iko zvino unofanirwa kuzorora.
Ndiyo Jennifer, na nitakwambia zaidi kuhusu njia za kuzuia maambukizi mara tu tutakapofika nyumbani. Kwa sasa unapaswa kupumzika.
Pavakasvika kumusha, Lady Tata vakakumbira vanhu kuti vagovesa moto mukuru pakati pemusha.
Walipofika kijijini, mwanamke tata aliwaambia wanakijiji wawashe moto mkubwa katikati ya kijiji.
Apo moto wakatanga kubaka, vana navabereki vavo vakagara vakaukomberedza. Ndokutanga kubvunza mibvunzo pamusoro pebilharzia. Pakuungana apa pakambotishamisa Lady Tata asisaonekwi. Izwi rake chete ndo rainzwika.
Moto ulipowashwa, watoto na wazazi wao waliketi kuzunguka moto na kuanza kuuliza maswali kuhusu kichocho. Katika mkusanyiko huu ulikuwa wa kushangaza kidogo. Mwanamke tata hakuweza kuonekana. Sauti yake tu ndiyo ilikuwa inasikika.
Lady Tata, chiremba vati unogona kubata bilharzia nemvura ine utachiona zvinosanganisa mvura yekunaya here?
Mwanamke tata, daktari alisema unaweza kupata kichocho kupitia maji machafu. Hii inamaanisha hata maji ya mvua?
Kwete chenai moyo, kwete mvura yekunaya. Iyi inobva kudenga yakachena, uye kwete mvura yegungwa. Munyu uri mumvura yegungwa unodzivirira gungwa kubva kumakonye.
Hapana Jennifer, sio mvua. Mvua hutoka angani na ni masafi kama inavyoonekana. Na hata maji ya bahari Chumvi katika maji ya bahari hulinda maji ya bahari dhidi ya minyoo au vimelea vya ugonjwa.
Mapinduriro akaita mibvunzo akaita takagara padivi pako iye asiri.
Jinsi alivyojibu maswali ilionekana kana kwamba alikuwa ameketi karibu nawe, lakini hakuwepo.
Kushambira nemadziva nemunzizi zvine njodzi. Zvipembenene zvinopinda muganda remunhu, zvichinopinda munyama uye zvinoenda muropa, matumbu nekune dzimwe nhengo.
Unapenda kuogelea katika maziwa na mito. Ni hatari sana. Vimelea hupenya kwenye ngozi ya binadamu na kuingia kwenye mfumo wa damu na kuhamia kwenye ini, tumbo na viungo vingine.
Ashile ditata munoziva kunakidza kwazvinoita kushambira nekutuhwina, uye munoziva kuti hatina manharembozha, mafoni ekutamba nawo magemu.
Lakini mwanamke tata, unajua ni kiasi gani tunapata raha kuogelea na hatuna vifaa vya kidijitali vya kucheza game?
Ndinozviziva kuda kwashe, asi unogona kushambira chete mvura isina njodzi. Uye kuti mvura ive isina njodzi, inofanira kumwaiwa mishonga inozikanwa kuti inouraya utachiona.
Nafahamu Eric, lakini unaweza kuogelea tu katika maji ambayo ni salama. Na ili maji yawe salama, lazima yanyunyuziwe kemikali maalum ili kuua vimelea.
Toma ya zivarese sei.
Je, tunanyunyizaje ziwa zima?
Maona, zvinenge zvisingaite kupfapfaidza dziva rose. Ndosaka zvichikurudzirwa kushambira nekugeza mumvura yakachena.
Unaona, ni ngumu kunyunyiza ziwa zima. Ndio maana inashauriwa kuepuka kuogelea na kufua katika maji ya ziwa au mto.
Ndingabatwa nebhewazia here kana ndikachera mvura yekugeza nemugomo murwizi ndoishandisa kumahombekombe erwizi?
Je, ninaweza kupata maambukizi ya kichocho ikiwa nitachota maji ya kuoga kwenye ndoo kutoka mtoni na kuoga pembezoni katika ukingo wa mto?
Hongu, unogona kutapukirwa.
Ndiyo, unaweza kuambukizwa.
Kana ndikabata munhu ane bhewazia, ndingaiwana here?
Je, na nikimgusa mtu ambaye ana ugonjwa wa kichocho, naweza kupata ugonjwa wa kichocho?
Aiwa, haugone kuiwana nekubata kana kuchengeta munhu anayo.
Hapana, huwezi kupata ugonjwa wa kichocho kwa kugusa au kumtunza au kumsaidia mtu aliye nao.
Ndingaiwana here nekungobata mvura ine utachiwana kunyange kwenguva pfupi pfupi?
Na je, ninaweza kupata ugonjwa wa kichocho kwa kuguza tu maji machafu hata kwa muda mfupi?
Hongu, ndosaka iwe nevabereki vako muchifanira kushandisa mazambuko kana muchienda kumapindu enyu ekudiridzira kubata utachiwana, kudzivirira kubata utachiwana.
Ndiyo maana wewe na wazazi wako mnapaswa kutumia madaraja mnapoenda mashambani ili kuepuka kugusana na vimelea.
Vana navabereki vavo havana kumboona ledi tata vachienda. Vakataura kwenguva yakareba. Vese vakabva vabatwa nehope. Pavakamuka anga atoenda.
Watoto na wazazi wao hawakumwona mwanamke tata akiondoka. Baada ya mazungumzo marefu, wote walilala na walipoamka alikuwa amekwisha ondoka.
Thank you.
Asante sana.
Thank you very much, Dr. Kagui and Olubayo. Yes, that was very nice. Can you hear me? Okay. We'll quickly move on to our next item on the agenda, which is a summary of experiences from healthcare staff. I'd like to invite Dr. Amina Yusuf to share with us some insights.
Good afternoon, everybody. Good afternoon. Schistosomiasis and diagnostic challenges in women living with schistosomiasis in endemic areas. So I'll take you through those outlines. I think from yesterday up to now, everybody understood what is schistosomiasis. We have been talking about the schistosomiasis. Schistosomiasis is a neglected disease caused by Schistosoma hematobium and the other species, Mansoni and Japonicum. So this disease is transmitted through contact with the infected water and through the whole life cycle. How do one get the disease? From the life cycle, if one gets contacted with infected water, she gets the secarians enter the body through blood vessels and through the blood vessels, these secarians lose the tail and just get to reproduce by the male and female. When the adult male and female, they get through the sexual intercourse and they get to produce the eggs through the blood vessels with the plexus of the blood vessels in the bladder, and these eggs, they just get to go on the other reproductive parts, and some of these larvae, they get through the lungs, the liver. That's why when Crescencia was just explaining about the periportal fibrosis, so it's just through the life cycle. So through that, some of the eggs are released via the urine and the other part through feces, and the life cycle continue. So the eggs, when they hatch in the water, they produce meracidium, and through the intermediate host, depending on the type of the species, the life cycle continue to the snail. And then there are some processes like going on the snail and then later on the life will continue by producing the secarians again via the human being. So knowing about the schistosomiasis, we have the female genital schistosomiasis. So how do one get the female genital schistosomiasis? The same life cycle. Then if it gets to, the eggs are produced via the reproductive organs, like the eggs are released on the ovaries, fallopian tubes, and vagina or cervix. These eggs, whether the dead one or the live eggs, they just lead to the inflammatory processes through response of the host immune response. And then if somebody had immune response after releasing of the eggs, then some inflammatory cells are released, like the lymphocytes, the eosinophils, and the monocytes. And then later, one get the fibrotic changes, and these fibrotic changes later they lead to the lesions which we are seeing during clinical practice, and that is female genital schistosomiasis. So the disease affected 56 million, estimated to affect 50 million women and young girls worldwide, and the prevalence seems to be 30 to 50% in high endemic areas. So how this genital female schistosomiasis present? So some of the women, they came with a discharge vaginally, whether they have a abnormal discharge or they discharge blood. Some of them, they present with bleeding after sexual intercourse, the so-called contact bleeding. Other women, they present with genital itching or burning sensations, like other presentation with other infection. Some of them, they present with the pelvic pain, pain during sexual intercourse, dyspareunia, and some of them, they came with the vaginal ulcers or ulcers on the other part of the vagina. So if these symptoms are not intervened, they lead to complications. And some of the complications seem to be infertility, sub-infertility, miscarriage or ectopic pregnancy, anemia sometimes, menstrual disorders, premature birth, persistent abdominal cramps, or increased risk of sexually transmitted disease like HIV, and sometimes can lead to cervical cancer. So these pictures are took from the atlas, the WHO atlas. These are some of the presentations we are seeing when you do the gynecological examination, either by visual or sometimes with the aid of the colposcopy. So the first one on my left, that is called labile papules. The next on my right, the upper one, I don't know if you can see clearly, those are abnormal vessels. The one down there on my left, that is called the grain sand patches, and the other one downwards in my right, the yellowish sand patches. So these are the common symptoms, the common presentation of the genital female schistosomiasis. So when we do the the gynecological examinations, what do you see? So the one I've shown before, the pictorial presentation, that is found in one of the female during the gynecological examination. You see those are homogeneous yellowish sand patches. The whitish thing you are seeing, those are just cotton wool somebody was trying to clean. So the grain sand patches, these are seen from the clinical examinations. So you can see from the cervix, those are the vaginal wall. Those are seen like from the atlas, the green sand patches. And you can see the abnormal blood vessels from the cervix. Yeah. So sometimes what we see during the clinical assessment, you can see other things like the patches from the cervix or vaginal wall. Those are trichomoniasis. And that is, the below is the normal cervix, and the other one is the cervix with the cervical cancer, a suspicious one. So what are the challenges? What are the challenges on the diagnostic of female genital schistosomiasis? The challenge we have, like, these symptoms are the same as symptoms of other diseases of sexual intercourse. So sometimes it's very difficult to differentiate whether this one is having the schistosomiasis or this woman is having the sexual transmitted disease, but because they present the same. As I said before, someone come with a contact bleeding of which you don't know, is she suspicious of malignancy? Does she have early stage of cervical cancer? Or someone presenting with itching vaginally, whether she's having candidiasis or she's having the symptoms for schistosomiasis. So healthcare workers, most of us healthcare workers, we are not capacitated to diagnose female genital schistosomiasis. So this is also the challenge on diagnosis. And we are not very sure if the drug we are providing, like the praziquantel, after diagnosing female genital schistosomiasis, is it really going to treat, is it providing the healing of the problem this woman is having, or are we just giving for the sake of treating ourselves psychologically? So I think you asked the question about does the schistosomiasis bring cancer? Okay. I can respond this way. For you to have cervical cancer, you need to be infected with the HPV virus. So there are other risk factors which can contribute for you to develop cervical cancer. As we all know, like everybody in lifetime has been infected with the HPV virus, but we don't suffer from cervical cancer. Those who suffer from cervical cancer are the ones who harbor the virus which are persistent in their body. So if you have persistent serotypes, and at the same time with the increased risk of, like if you have the schistosomiasis, that means sometimes we have seen like it has a lesions, you provide the ulcers. And if you have an ulcer, you increase the chances of also transmission of the sexual transmitted disease. And if you have the persistent HPV virus, you are at risk of probably developing the changes of the cells. So you can suffer that way. So the HIV risk increased with the schistosomiasis, and at the same time you are at risk of probably developing cervical cancer with the combination of all what I talk about. Thank you very much. It was a short presentation. If you have questions and...
Thank you so much. Can I get a 30-second Swahili summary? Quick one.
Yeah, nilikuwa najaribu kuelezea kichocho ni nini, kinaambukizwaje, na mwisho wa siku kuna kichocho cha via uzazi ambacho wanawake wanapata. Kwa hiyo nilikuwa najaribu kuelezea kichocho cha via uzazi kinatokanaje, sababu watu wengi wanaelewa unapata kichocho ukikojoa, unakojoa damu, ukapresenti na kukojoa damu, maumivu ya chini ya kitovu, lakini mwisho wa siku bado kuna wanawake wanaugua kichocho cha via uzazi, ambapo sasa hivi ni watu wengi sasa wanafanya utafiti kwenye hilo eneo. Mara nyingi dalili za kichocho cha via uzazi kinafanana, dalili zake zinafanana zaidi na dalili nyingine za magonjwa yanayoambukizwa kwa njia ya kujamiana.
au magonjwa mengine ambayo wanawake wanakuja nayo kwenye kliniki za kila siku. Kwa hiyo dalili kama mtu kutoka uchafu sehemu za siri za kike, akaumwa tumbo la chini, akawa na vidonda ambavyo kuna magonjwa mengine ambayo pia mtu anaweza akaja na vidonda. Lakini pia baada ya kujamiana, baada ya tendo la kujamiana ukapresent au ukawa na dalili ya kwamba unatoka damu, lakini hiyo ni dalili pia ya mtu ambaye yuko kwenye dalili za awali za maambukizi, yuko kwenye mabadiliko ya awali ya saratani ya mlango wa kizazi, au ana uambukizi kwenye mlango wake wa kizazi au via vya uzazi. Kwa hiyo mwisho wa siku tumeona pia kichocho cha via vya uzazi kinaambukizwa, kinatokanaje? Ni pale ambapo ukishaambukizwa kichocho, yule mdudu akaingia kwenye mwili wako, anakwenda kwenye mishipa ya damu, na kule mara nyingi anayeingia wa kiume na wa kike wana change na wa kike anazaa mayai. Kwa hiyo yale mayai mara nyingi kupitia mishipa ya damu inayokwenda kwenye kibofu, lakini mengine inayokwenda kwenye via vya uzazi. Kwa hiyo mama huyu mwisho wa siku mayai yakitolewa yakaenda kuwekwa kwenye mlango wa kizazi, kwenye uke na kwenye mayai. Pia sehemu kama mishipa ya mirija ya uzazi na kwenye mfuko wa kizazi. Kwa hiyo mama huyu baadaye kama hajapata matibabu, kama mayai yakiwekwa kwenye mirija, huwa kuna mabadiliko yanatokea pale. Kwa hiyo mwisho wa siku mirija ikiziba, manake huwezi upata mtoto. Lakini pia kwenye mayai yanaita athari, lakini pia kwenye mlango wa kizazi na Kwa hiyo tumeona mwisho wa siku madhara yatokanayo na kutokutibiwa kwa kichocho cha via vya uzazi kama mimba kutoka, kuzaa watoto mapema kabla ya muda, kutokupata ujauzito. Tumeona madhara mengine, na mwisho wa siku hiki kichocho cha via vya uzazi kinahatarisha pia mtu kuugua saratani ya mlango wa kizazi, kama tu huyu mtu atakuwa ameishi na kirusi kinachosababisha saratani kwa muda mrefu. Lakini pia uwepo wa vidonda una riski pia ya kusababisha mtu akaambukiza magonjwa ya zinaa.
Thank you, Dr. Amina. Shona, please.
Shona one.
Thank you.
Okay, I'll do it. Yeah. Zataura na chiremba vatizo parazia rinowanikwa muchibereko iparazia rakaiti indi parazia isiri iwa kodzero inofana kuiwa nokuti vanhu vakawanda vanokuwadzwa naro nokonzeresa zvakawanda sere kusanganisira kusateerera zvakanaka, kusabata pamuviri zvakanaka, kana kusatopedzisa kusanga tozoita vana. Munhu wataura ndezvekuti pabarazia racho rinotoda kuti tange nguva ichiripo isaregererwe panenge nayozuva isakwanise radhineja nhengo dzechikadzi kana kuchibereka kwavanoti. Saka unenge uchitoda kuti vana vasikana vanenge vowana basi ndo zvakabata neno kana manzwa wawo here asi can I add just something on female gender following the comment on cervical cancer question you asked.
Okay.
Yes. There was a big challenge. We did the FTS in Zimbabwe, and we were collecting pap smear and also the biopsy. And a lot of women were misdiagnosed that I think they are having cervical cancer. But when we took the biopsy, they noticed that it was just so it wasn't cervical cancer. It was schistosomiasis, which had deposited some egg calcification near the cervix. So you see, there's misdiagnosis. Although when you go further to do the cervical cancer test, you find it's negative. But the cervix is damaged by the deposition of the egg. Thank you.
Thank you very much for me, something which I didn't talk. Actually, it's very likely, like, because most of us, we don't know how to do diagnosis. And one among the diagnosis of the female psoriasis is just taking a tissue, leave alone seeing with the aid of probably the colposcope, but taking a tissue also, you can diagnose the psoriasis eggs. So there was a research done at Bugando, Kuhas, like, yeah, it's true, I do agree, like, in our country with the low resources, most of diagnosis of pre-malignant lesions, we are doing the VIA, and very few areas which they are doing pap smear. Like in our setup, the pap smear is done in the higher setup health facilities because the pathologists are available there. So most of the time, women are coming from peripheral, probably they're having large lesions, and there's a, protocols of when you are doing VIA, you find a large lesions, these are not treated by cryotherapy. They have to be done a lip. So most of these women who are done lip, when you do lip, it's a treatment at the same time the diagnosis. So this sample was sent for histopathology. So somebody was reviewing all the samples for the lip test. And then some of the samples, they came to have this psoriasis. I don't think Professor Mazigo will add more. So we got some of the women who are having schistosomiasis and diagnosed. So this just wake up our mind. We are missing something. At the same time, as you said, like when we are doing clinical assessment, you might find some things of which you don't know. For those who are just doing VIA with they don't have backup knowledge of the female genital schistosomiasis. Their role is just doing if this is VIA or they are doing pap smear, somebody seeing something else, whether in the vagina or the cervix, cannot do anything or cannot even report. Like the female genital schistosomiasis, this is reportable, undiagnosed or untreated. So you find something which you don't know, whether it's a lesion due to schistosomiasis or something else. They are treated. This also bring up a wake-up mind, like the diagnosis of those who are doing VIA and found to have VIA positive. Some of them, they are not VIA positive. It's a false positive of which they are treated. As you said, some of the people were treated not have cervical cancer, while the lesions were not of cervical cancer. They were the lesion of maybe the scarf or schistosomiasis, the female genital schistosomiasis. So I wanted to comment on that.
I wanted to ask.
30 seconds.
30 seconds.
30 seconds.
I just wanted to ask, at settings, like in the rural clinics, what would you recommend for female genital schistosomiasis on women? You know, the complaints they show that this woman is not STI, but it's something which is in her sexual thing. So what would you recommend is something which can be done at the peripheral where schistosomiasis is?
Yeah. For somebody with my thought, I would like in the peripheral where they cannot done much, probably they can do urine. Probably, I do think urine for someone who came probably having discharge, of which most of the time the peripheral, they don't even put the speculum. So they just treat the symptoms by giving some of the antibiotics. If I just come there with a discharge, and that is the thing, of course, we are trying to insist. If one comes to you, like having those gynecological symptoms, don't deny putting a speculum. That will save her rather than giving medication. So I would like recommending for anyone who comes to you, symptoms of which you don't know, maybe for the high endemic area, it's better to just having those small diagnoses like the urine and the stool to exclude probably the schistosomiasis, of which probably somebody has taken medication, but still this vagina or on the cervix. So speculum examination is also still mandatory. Probably you can pick something. So doing speculum better.
Thank you very much, Dr. Amina. Shall please clap for her. Thank you. We quickly move on to the last bit on our agenda. A very, very important part, if not the most important. We came here to amplify and hear the voices of the affected. It would be futile to leave here without a roadmap to be able to continue this movement. It doesn't end here. We need to continue to amplify the voices in order to make an impact towards the fight to eradicate NTD. And so I would invite Dr. Yasiyopewa, did I say it right? Yeah. To lead us on the roadmap. Thank you.
Talking about the female genital schistosomiasis, it is a big problem. Well, I've had years of working on it, 10 years, full-time doing biopsies, pap smear, and whatever, colposcope and so on. But it's the job of the gynecologist. We need to protect the young children, especially the girl child, because before, when they're still girls, they've got the infection, that's when the damage taking place. Whatever you would do when they are married to be too late. So from policy, it's like children, girl child may need to be treated just like the mass drug administration period. Because if you go and you see the number of young married women in the rural areas not being able to conceive, people just associate it with the other problems and so forth. It could be bilharzia. If treated early, we protect that. Thank you.
Thank you. Thank you, Taka. Hello. This one is hungry, doesn't have enough energy. Okay. Thank you, Amina. Thank you, everyone. FGS is a big thing. Thank you so much. I was so happy to hear from Taka, the experience. I'm just from the field. We're doing FGS, not clinical, but from the implementation science point of view. We want to integrate screening and treatment of FGS with the pediatric vaccine program. Hey, what I found there is really shocking. Exactly what Taka is talking, what Dr. Amina was talking just a while ago. It's a big thing. We really need to do a lot of things. It's one of the areas which is neglected. There are so many affected women, girls and women in the society. But they stay with it, they suffer with it. We should not forget them in this movement. Okay. Mine is, as Derek put it, we started yesterday, and a lot has happened in front of us. We have discussed, we have said a lot of things in relation to disabilities which are brought by NTT infections. This session might be one of the very short sessions we have had, but very effective. Or it might end up to be one of the longest sessions, depending on how you guys behave. If you cooperate, we'll do it so fast. If you don't cooperate, it will take us long, because we must get our pathway. We must know what is next. We cannot leave from this room unless we know what is next. Okay? Are we together? So I don't know why they decided to give this session to me, but let me try to do justice. Before we start rolling with the propositions, I will explain everything. I want to know who has not altered a single word since they came here. If you didn't say anything, just raise your hand. Raise your hand if you didn't say anything. Have we all said something? Okay. Yeah, Jenny, you have to say something. Yeah. And even Gareth. Gareth was busy with the camera. So I want everyone also say something. Because whatever we agree here, all of us who have proposed the way forward. Am I right? Okay. Yesterday, when we started, I was the first to bring forth a teaser. I teased in some issues, which let alone the guest of honor expanded in his speech. We discussed a bit about the complexity of the morbidity and disabilities brought by the NTTs. We also touched on the impact, not positive, rather negative impact of the NTT-derived disabilities and the way it pushes our brothers and sisters into poverty, especially if they end up losing self-esteem. And so many issues which came out yesterday. Yesterday, we also heard from the affected voice. We were encouraging them to speak up, to say, to open up. What do they think should be done for things to change? For them and the people who are represented by these colleagues to also begin enjoying their lives just like any other person who doesn't have any kind of disability. Of course, we had stories from our colleagues. We also today had papers, very breathtaking papers, I can say. You know, you listen, you see the images. Oh, yeah, you say it tells you a lot. It makes you think. We had last one is the fourth or third paper. They are all very, very touching. From Ukerewe, Mwanza, from Sudan, and then from again Itilima, Madam Amina, and all of them. They speak loudly enough for us to think hard. What next? So, having listened to all those discussions, since I knew from yesterday that it was I and Band actually to stand here and coordinate this session. Then today morning I realized Banda's name was removed. I don't know who removed it, but that is the case after the meeting. I have I've jotted down about 5 areas, actionable areas. Forget about the typo, there is no S, actionable areas, which will guide us to discuss the roadmap. The middle column and the last column are not populated, even though I have my own table which is populated. And I don't want to dictate to you the way forward. At least the first column, I said I must do justice and then give you the opportunity to also review them. And then we agree on the first column before we move into the second column. Are we together? If disagree up, okay. Now, who is speaking, Shona? But you understand what I'm saying, isn't it? Eh? Swahili, okay. Kuanzia jana, kazi yangu hapa ni ndogo tu, tunakuja kukubaliana baada ya mkutano wa Zimbabwe na mkutano huu wa Zanzibar. Kitu gani kifuate ili kuendeleza kuendeleza hii kazi ambayo ni nzuri tunaifanya kwa ajili ya kupaza sauti za ndugu zetu walioathirika na maradhi ya NTD na kupata ulemavu. Tumefanya Zimbabwe, tumefanya Zanzibar, tunamalizia leo, lakini hii isiwe mwisho. This meeting shouldn't be the end of the amplification of the affected voices. Kwa tunataka hili jambo liwe endelevu, ili watunga sera walisikie, watendaji walisikie. Sasa tunachokuja kujadiliana muda huu dakika chache hizi nilizopewa ni nini kifanyike ili haya mazuri tuyo discuss yaende mbele. Tumeelewana Waswahili wenzangu? Good. Shona.
Yeah, saka baba vari kuti takusvika pakufunga kuti nyaya yakatanga iyi ichaenda nekupita papanapa. Saka vambotanga zvavo vachiita sekakutamba kuti asina kumbotaura ngaasumudze ruoko, vamwe vakasumudza vamwe vakaramba, asi havana havo kutaura. Tikuvaziva. Vakazoti iye zvino tasvika pabhodhi apo, kompyuta yavo yanga yakadzima. Neno zvavanga vachiita, kompyuta ichidzima. Saka vazomutsa kompyuta, saka zvinhu zvapabhodhi apo. Vati hanzi sekeni yekutanga iyi vakatifilira. Saka vakuda kuti manje isusu tichifila kumwe kwacho kumberi uko. Saka paina ndinyatsi kuona, saka pakanzi policy recommendation zvinomugona kuverenga institutions of affected voices, communication and advocacy, kurava kutaurirana nezvimwe zvinotera tozozvitaura ikoko kana vatasvika. Right, over to you, sir.
So we have, thank you for even going through the table. I will do English and then go back to Swahili. We have 5 areas. We can have more than this, but don't bite more than you can do. What? You can chew. Am I right? These are heavy. Number 1, actionable area number 1 is the policy recommendation. Recalling the Zimbabwe meeting, and then following this meeting, there are clear policy areas which we need to provide recommendation. A document which we are going to develop, be it a report or a policy brief, whatever name you give it, must have strong policy recommendations which would demand action from the world body, WHO, but also from the country Ministry of Health. Because they submit this, they also get it from WHO. Before they get it from WHO, they must have them for further discussion and action. So we are going to describe what we mean by what we want under policy recommendations. And number 2, institutionalization of the affected voices movement. This is very important. I think it started, when it started, it was like, even myself was like, how will this thing look like? How are we going to do it? But bit by bit, everyone is getting to understand and get interested, attracted to it, that this is a noble movement which we really need to institutionalize. What do I mean by institutionalization? At the moment, the Affected Voices movement is driven by our colleagues from Edinburgh. Edinburgh under TIBA. I'm not trying to say that is bad, that is excellent, but we want to give it more momentum, more energy. We want to have some context issues raised at the local level. So it is important, this movement, we have a global sort of an institutional framework, and then we have country chapters. And all the information needed, actionable issues under country chapter and the global chapter should be articulated clearly. And that will keep us going because we create demand, and that demand will push us to act. Are we together? You have to provide input there, even though I've provided some input already. Communication and advocacy. Banda, I think you provided a very good comment when Concecia finished her presentation. What we have done, one can sit down and write up probably 6-7 pages, high quality pages, describing the stories and the science which was presented. It's huge evidence. And then that can be communicated. Whether, I don't know how you put it, it's a commentary or paper, because this is also part of research. And we got your consent, you signed the consent. So we wish to share this information for the whole world to know the plight brothers and sisters who are affected by NTD, secondary complications, go through. So that's one of the communications. And so forth. Advocacy. How do we make everyone understand this issue? And anything that you think is resonating in your mind as far as education and advocacy is concerned, I want to hear your voices. Systemic issues. Wow, this was also, especially today. It started yesterday when Mashaka was talking here. He spoke about the need for medical insurance or health insurance, if you like, because most of the affected, they cannot afford the cost for health care. If you remember what he described in front of us here, he was hospitalized for 3 months. Yeah. So that was a hefty bill. Don't have a job. You had a small business. It's dead because you are not there. Who is going to foot that bill? Leave alone hospitalization. Access to service. That compelled me to think about systemic issues. We'll articulate those issues and recommend what should be done at the global and country level as the way forward. Community engagement to raise awareness about NTD-derived disability. This is cross-cutting, but as I said, let me give it a deservedly position. Be it clear, everyone can see it. How do we want to engage the community? It was said here today, yesterday, and today. Community, some community members, they are not aware that this is a disability derived from an infection. They stigmatize victims. They don't even provide support. It is simply because of their ignorance. They think probably somebody who suffers from those serious disabilities has bad luck, probably, forgetting that anybody can suffer from these complications. We saw from Sudan an old man, he was 56. A Sudanese old man with a imagine 59. So that speaks very loudly. I might be enjoying here My mom, who is 75 this year, before you know she succumbs to it, because she's in the village, even though I've tried as a son to provide a lot of support. So, we need to do something as far as community engagement is concerned. So, are we ready to discuss? Jamani Waswahili, nilikuwa naelezea kwamba haya ni maeneo ambayo tunataka sasa tukubaliane tunayapelekaje mbele ili kuhakikisha kwamba ili jambo la kutoa nafasi kwa waathirika kuzungumza kama mradi au mpango uendelee, usisimame. Baada ya mkutano huu tuendeleze hili gurudumu, tuendelee kusema, tuendelee kuwatengenezea maeneo ya kusemea kwa kuzingatia sera. Na mambo ya kisera yaliibuka hapa, lakini pia natakiwa hili jambo litengenezee mfumo, taasisi, ili lisisimame kama mradi wa utafiti. Shouldn't be like a research project, should be an institution. Then within that institution, then things, yani kwenye taasisi hiyo ambayo tunaitengeneza sasa, hii miradi na program mbalimbali za kuhakikisha kwamba sauti za waathirika zinafanya nini, zinasikika. Na namba 3 ni mawasiliano na advocacy, Kiswahili inaitwa advocacy, na uhamasishaji, kwamba wananchi wengi hata na wasomi wa vijijini wa mjini wengi wakimwona huyu bwana anatenda, huyu anabusha bwana, anamjambisha, anafanya tunajua kwamba mjini na kadhalika na kadhalika, lakini hawaelewi. Kwa lazima tutengeneze utaratibu wa kuwasilisha na kuwapa uelewa mfano wa mambo ili waweze kutoa support kwa waathirika. Lakini pia kuna mambo ya machapisho ya kitaalamu na kadhalika na kadhalika. Hiyo ndio la 3. La 4 lilizungumzwa hapa kwa namna tofauti. Ni mambo ambayo yamekaa kimfumo, kwa maana mfumo wa afya. Hata kwenye mfumo wa afya kuna vitu kama 6 ambavyo ndio vinafanya kitu mfumo wa afya. Tutajadiliana hayo mambo, kwa mfano upatikanaji wa huduma, mambo ya fedha kugharamia huduma, kuna mambo ya upatikanaji wa madawa na kadhalika na kadhalika. Hayo ni mambo ya kimfumo. Na hayo nayo lazima tuyachukue ili tuone sasa tutayafanyia kazi namna gani. Na la mwisho ni namna gani kuishirikisha jamii. Tuishirikishe jamii yetu ijue, wakiona mtu ana dalili hizi kama alivyozungumza Princess walichokifanya Ukerewe ni kitu cha kuiga, kwamba umesensitize jamii, imeelewa, akiona hivi wanamsaidia bwana, hospitali pale kuna huduma. Jamii inabidi ielewe ili iweze kuweza kutoa msaada, lakini pia tu kutoa msaada hata kuishi na hawa watu, kuzungumza nao, kuwapa matumaini na kuwasaidia na wenyewe kukamata fursa na kuishi maisha ya kawaida. Tumeelewana? Bravo. Asante. Okay. So how do we go? I don't want to share my table. I want to hear, when I hear your recommendation. And who is noting? There are people writing, isn't it?
And so it has got focus. Saka tungo fita boxi pekutanga apo teshitaura nezve gwara rehealth tingati policy anditya pechi 2 apo totaura nezvekuti isusu nemi sevanhu vari kunzi ma-affected voices tingafoma here, tingarongeka sei kuti tigone kubatsirikana tiri group. Then yechipiri iyo inyaya yekutaurirana nekukurukurirana, sezvataona imwe yacho communication chibhuku ichi ndochinonzi. Then iyo yakanzi systematic issues, health system responsiveness for disabilities. Vari kuti muhealth system yatingati system vangaita sei kuti vabatsire vanhu vakaremara kana vari kurwara zvirwere izvi. And then yekupedzisira iyo community engagement, tiri kungotaura nyaya yekuti kwatinobva vanhuwo vasina kuuya kunoku vangaita sei kuti vaziviwo zvatakuziva, varege kutifungidzira kuti tinoroya kana kuti takaroyiwa kana kuti izvimwe zvakangodaro.
you, Takwi. Takwi? Yeah, I don't want to misspell your name. Okay, number one, policy recommendation. What do you say? How should we describe it? People are taking notes, please note. I'll be just... Okay.
Thank you. I was thinking to describe it this way, maybe technical guidelines, because in our context, the policy institutions are there, but now technical guidelines and also cascading this to, top-bottom approach. So we need technical technical guidelines to entities management. Yes.
Before, if we don't have, I'll go. I suggest multi-diagnostic tools. I think one of the nurses actually shared that, because there are co-infections, comorbidities. We diagnose, we seize malaria, and we forget about the others. So if it's possible to, as a first step, do multiple diagnostics, so that the fact that there's malaria doesn't mean there's no schisto or there's no filariasis. Anyone else, please?
Kits must be very simple to use at the clinic level. So the diagnostic.
So maybe rapid or point of care diagnostic.
I feel that government should increase budget for management of entities, but increase budget allocation for the management of entities.
While we wait for the next contribution, does someone want to translate? Quick. Or should we skip that and summarize? Okay.
Should be free. All right. Hello. It should be free access to medical help at clinic for all entities, just like we do for HIV and TB.
Maybe also adding on, probably they put a certain chart of diagnostic criteria, like when you are like in HIV, if you are having this symptom and this one, you will be highly suspicious of this. Probably it will help for somebody to order the proper investigation. You add a clinical presentation chart, probably of the symptoms presenting. clinical symptoms or presentation chart. Sorry, so can I just go back through this quickly to be more focused? I'm basing this on what I've heard from our affected voices. So the developed guidelines for management of NTD disabilities, it should really extend to all morbidities because the disabilities do not take into account things like the hidden morbidities like vomiting. So it's NTD disability and morbidity management. And these guidelines should be both policy guidelines and technical guidelines because we heard from our colleagues from Zimbabwe they wanted technical guidelines, but we also heard from Humphrey that there's no WHO policy guidelines, so we need to capture that. The multiple diagnostics for other diseases, it needs to be multiplex, yes, differential diagnosis that can distinguish a person with fever from malaria based compared to a patient with fever from LF. And then the increased access to point-of-care rapid diagnostics. I think we heard from Tafazwa yesterday a very important aspect that we have to take the interventions to the patient. So we need that distance between the diagnosis and the intervention. You know, if a person is being diagnosed in primary health care and the treatment and intervention is tertiary health care, what can we do to bring it closer to the patient? So conjoined diagnosis and treatment. And then the other thing we heard yesterday was that diagnosis without treatment or without management is worthless. And that was a point that Humphrey repeated yesterday. We even went as far as saying that some of these diagnoses are nothing more than death sentences. Because you're telling a person, this is what you have, it's very serious. In order for you to be treated, it's going to cost this much, or you need this operation which you can't afford. So that's really important.
My sister had switched me off. I think it's important, I said this earlier, that we provide clear treatment plans and clear referral pathways so that the person does not go around in a maze trying to get help. Treatment pathways and also the referral pathways. Yeah, and something that I think was not mentioned here is we are looking at the health system as if it is a monolith. There is a constant jumping between the private healthcare and public healthcare and faith-based missions. So that needs to also to be integrated. So that if you're coming with an X-ray from the private sector, it must be accepted in the public sector. Because sometimes you can come with your bunch of X-rays, they'll tell you go and get some more taken, and yet it is expensive for people who are doing out-of-pocket expenditure.
I think I also heard as part of our, from our colleagues, I think it was Sister Kwenda who mentioned this, the extension of our NTD control programs should be community-based, capturing the whole community, so that we ensure that we are catching the little ones early enough when we can still do something to stop the pathology from infection. So a fully inclusive NTD treatment and management plan.
Sorry, Paul, one more. What is the curriculum like for the medical personnel, nurses, the pharmacists, and the doctors? Does the curriculum cover NTDs so that you have a higher suspicion index for NTDs? I think it was my sister, someone was talking about someone presents with a fever and we just think of malaria. But if you have a curriculum that tells you, listen, when someone presents with a fever, it could be a number of things, and these are the possible things. So curriculum, I think curriculum, curriculum content that is, I think I will be rough here. We need to develop a curriculum that speaks to the local context and the local problems, instead of taking a curriculum that was developed in another country that doesn't have the problems that we have. But I shall shut up here.
To our country, I think that has no problem. Like the clinician knows, he studied all the diseases and knows how to diagnose. And I was worried in the other, I don't know, on the other countries, like if the nurse is the one diagnosing the patient, I might be worried. I don't know the curriculum of education, but for our setup, it's the doctor who do the diagnosis. And they study all the diseases and they know how the differentials and to work on it.
Lot of recommendations. So all that we have recommended, they will appear in the report. The policy document which we will also submit to the authority, WHO and the Minister of Health in our country or to our country. Do you allow me to move to the next? Do you interpret this as well? Later, quickly, you scan through. Yes. And then, institutionalizing the movement. Banda, Takwi, Humphrey, Charlie. This is Hassan, and then practitioners as well who are here. This is ours. How do we institutionalize the movement? Wanda, what is your thought? This one I'm taking specific people.
Yeah. So I think we don't need to reinvent the wheel. If you go to countries, they have cancer societies or people who deal with certain diseases. And so they become a repository of information, and they also become a point of reference for people who want to know. Yeah. So setting up these organizations, people who are living with this type of diseases, and
some of them you may need funding from government to set up some seed funding to set up this, and then it can also be work hand in hand with government. So it tends to work very well with people. So you may have cancer societies, but you also have hospices in cancer that tell people that if you have cancer, this is what's likely to happen, and they come and give you help. So I think that is important in demystifying what's going on, but it also becomes a place where people easily go to for help, and then they can, the treatment pathways that we're talking about and the referral steps that we're talking about, these guys could be part of that.
I was just helping my brother to say he's nicely got to the door. Can you open the door to say how do we do it?
I was trained to speak like an old person. You go around and around in circles. No, I think it just needs either someone who's a clinician or an academic or someone who's a social movement person to just set up an NGO. Have I answered the question?
I was also suggesting a training and capacitation of the health personnel.
Training, can we put, remember, on the systemic issue, probably you might find, because you have service delivery, you have to capacitate healthcare workers. You can.
Okay, I wanted to say, as what is done in other diseases, for example, TB, from the national level, there's a director, and it goes down to the district level where we have a district TB coordinator. Why can't we also have the same thing so that anyone diagnosed with any NTD will be monitored through that person, and you will be able to be directed where he or she should get help than moving around. Maybe you have gone to this clinic, you don't know where to go, you go to the next clinic, they don't even know where to send you.
I think that is streamlined coordination system. Even though in Tanzania we have exactly the same system. We have national, regional, up to council level. We have coordinators that are all across. National, regional, district, or council. Yeah. Actually, at the council level, we have coordinators for the health department, the coordinator in the education department because of the school. Yeah. But this has to be, because we are writing for everyone, streamlined coordination. Okay. Yeah.
Where we come from, we've got the health center committees which represent the community. So I feel that in each of the health center committees, there should be someone with an NT so that they can contribute their strength.
Health center, is it at the level of a what? Or so I think we got them. Health facility governing committee or advisory committee. Yeah. Health facility, I don't know whether hospital or health center advisory committee. There should be a member. A member who has what?
Yeah, I just wanted to interpret. Takurukunzi kukafumwa makomiti pa ward level. Team ready, team ready to the affected question. Munoda ere kuipinda makomiti member. Tafadhali. Munoda ere ta committee member, watu uda uta chairman wake. All right. Saka iri open, all right. Donya saka ndio rutorwa panapa. Tichienda mberi tati tugadzira nzira. Ndizvatatanga kuti zvikuenderana kuti saka inovaronga kuti let us say system structures asiko kwatuka. All right.
one comment on scholars. We have to publish the output from this. Is that not communication? Yes. Publish. High level presentation meeting. We will know how to do this. Not necessarily the system. If you have anything
this can be one of the agendas when we prepare. Then we publish. You have to publish the outputs from this discussion. From the committee. I think that's anything else you think we need? Media engagement. But by the time we form the NGOs or whatever, media engagement is part of the, you see, is what we call program of